Director HR ACCL, Sri Biranti Das sir, Organizing Chairman, CIMECON 2026, Dr. Kshitij Mishra sir, Organizing Secretary, Dr. Arihan Jain sir, Chairman of Scientific Committee, Dr. Kalyan Sarkar sir, CMS of all the subsidiaries, our HODs, ex-CMSs of ACCL, esteemed faculty members, delegates, and dear colleagues. I, Dr. Sanjeevni Panigrahi, Coordinator, CIMECON 2026, take the privilege and honor to welcome you all to the pre-conference workshop of CIMECON 2026. This year's theme, Healthy Minds, Healthy Nation, Strengthening Healthcare Across Coal India, reflects our collective commitment towards advancing occupational health services and safeguarding the well-being of our workforce. We are deeply honored by the gracious presence of our respected Director HR, Sri Biranti Das sir, who has kindly consented to be the chief guest of today's pre-conference workshop. To invoke wisdom, positivity, and the spirit of knowledge, we now proceed with the ceremonial lighting of the lamp. May I request our respected Director HR sir, along with the dignitaries on the dais, to kindly come forward for the lighting of the lamp. Sir, please. Thank you, sir. The light we kindle today symbolizes knowledge, clarity, and our shared commitment to healthcare excellence. We shall now proceed with the Coal India Corporate Gate, celebrating the spirit, strength, and unity of our great organization. May I request everyone to kindly rise for the Corporate Gate.
हमारे हाथ औलाद हमारे Thank you, Sanjeevani. Good morning, all of you. Respected Chief Guest, Director HR, SECL, Sri Biranchi Das sir, dignitaries on the dais, our ex-CMSs, respected Mohan sir, distinguished faculty, dear delegates from different subsidiaries of Coal India, and my colleagues from SECL, and my dear HODs who are present here. Good morning and very warm welcome to the pre-conference workshop of CIMECON 26. What a wonderful day to start with. Today is our National Science Day, 28th February. The theme of CIMECON 26 is Healthy Minds, Healthy Nation, Strengthening Healthcare Across Coal India. We are deeply honored by the gracious presence of our respected Director HR as a chief guest today. Sir, your unwavering support from the very inception of this conference and your constant guidance and close mentorship throughout the planning process have been a tremendous source of encouragement and strength of the entire organizing team. Today's workshop sets the academic tone for the conference with focus sessions on key aspects of occupational health. The deliberations on ECG, pyrometry, ILO chest radiography represent critical tools in the early detection, evaluation and prevention of occupational diseases, particularly within the mining environment. These sessions are designed not only to enhance clinical knowledge, but also to strengthen practical competencies that directly impact workforce, health and safety. I'm confident that today's interactions will be insightful, engaging and professionally enriching. Once again, I welcome all participants and wish you a highly productive workshop. Thank you. Jai SECL.
Thank you, sir, for your inspiring and thoughtful words. It is now my proud privilege to invite our esteemed chief guest, Director HR APCL, Sri Biranchi Das sir, to address the gathering. May I request you, sir, to kindly deliver your address. Sir, please.
Suprabhat. Good morning to all of you. ब्रेकफास्ट नहीं हुआ है, आवाज़ नहीं आ रही है. हाँ, that's it. आप सबका नमन, वंदन, अभिनंदन. Welcome to ACCL. We are the host for this CIMECON 2026. I got to know that today's conference theme is Healthy Minds, Healthy Nations. When we started as a company in 1175, But in the Sam Altman's added to that, the people who do not who use AI will replace those who do not use AI. So now Medicare and has gone beyond. Now you can having robotic surgeries, and in near future, AI will be impacting the medical profession very in a big way. And as you know, we have stopped living in a VUCA world that was conceptualized after World War II. Now we are living in a Bani world after COVID, 2020, 2021, whatever you can say. And this Bani world is brittle, non-linear world, which throws up many unknown challenges. And we have to face the challenges. And these challenges can be overcome only we have a healthy mind. The main challenges before us as leaders of this great company, ACCL, or per se to all the subsidiaries, NCL as a whole, to have a healthy workforce. People should be ready to accept challenges. And Douglas McGregor's theory of why will come into place here, not theory X. Theory Y says that everybody should be ready to face challenges. I should not go dwell much into what management says. Nevertheless, I wish CIMECON 2026 grand success with all of your active participation. and hope that you are enjoying the hospitality of SECL. Thank you and God bless you.
Thank you, sir, for your motivating and insightful address. With this, we have come to the end of the inaugural ceremony of the pre-conference workshop. Now, we will move towards the academic core of today's pre-conference workshop, and we will start with it shortly. Everyone is requested to take their seats. Now we will be starting with our workshop. And for the first topic, I would like to request Dr. Deepak Paratkar.
Hello. Hello. I request the stage people to kindly remove the chairs and the tables.
Chest wall or ventilatory muscle defect. This is the force expiratory volume, which is 2550, and I just don't go through it. It is too much complicated for. But now this is peak expiratory flow which is the maximum flow in liters per second of air during a force exhalation. Normally it takes place immediately after the start of exhalation. Once we exhale forcefully, once we inhale forcefully and then we start exhalation, at the first what we get is the peak. Okay, so this is the force expiratory flow. Okay, this peak we should get, and then this is the effort dependent. Okay, so this is the reserve volume, and at the end of total lung capacity, at the end of total lung capacity, here is the total lung capacity. From there we start forcefully expiring, and then after that we ask the patient to go on expiring residual volume, and then once the residual volume comes, we ask the patient to inhale. So these are the two curves, main two curves. That is volume, this is volume, and this is time based, and this is flow, and this is a volume based. This is actually a curve, and this is actually a loop. I will show you. So this is a flow volume loop. Now this is a loop. What you should see in a spirometer. So here you can see that at the height of total lung capacity, okay, we start exhaling. Now you will be get confusing that sir, initially पहले तो आपने बोला कि भाई जो पॉजिटिव पॉइंट है वो इंस्पिरेशन है, अभी आप बता रहे पॉजिटिव पॉइंट, पॉजिटिव जो है एक्स एक्सिस से जो भी पॉजिटिव वो एक्सलेशन है. This what we see is the machine, what machine interpret. That's why when we exhale, the machine inhales. When we inhale, the machine exhales. It is a simple funda because it is a closed circuit. So when we start exhaling, the machine will inhale. So it will show that the air is coming to me. So it comes out to be positive. And when we start inhaling, the machine will show the air is going away from me. Just like ECG, PQR pattern, QRS complex, what we see, the lead, whichever it is showing that the electrical current is coming towards that lead, it's come out to be positive. And current going away from the lead, it is shown as negative. Similarly, here also the air is entering the air is entering the machine spirometer. That's why it is shown as positive, and this is the expiration. And inhalation, it is this negative thing. A normal flow volume loop is a combination of a triangle sitting on a semicircle. Okay. Exhalation is a forceful process, therefore there is a peak, and in inspiration it comes out to be a circle. Okay. While performing the spirometry, what all to be avoided prior to test? That is smoking less than 1 hour, alcohol less than 4 hours, performing vigorous exercise within 30 minutes, wearing clothes that substantially restrict full chest or abdominal expansion, eating large meals within 2 hours of the testing. If the study is performed for to diagnose the airway disorder testing, then following bronchodilators must be avoided. That is short acting for 6 hours, long acting for 12 hours, and for slow release such as acebrophylline, sustained release, and all those things we should avoid for more than 24 hours. For performing spirometer, we first what we do, we explain the process, we check the spirometer calibration, we explain the procedure to the patient, record subject's age, height, weight, gender, for calculation the reference value. In spirometer, the baseline or else the reference is according to the individual. The reference is not for everybody same. Okay, so what is the reference point? For every person sitting over here, the reference will be different. So all this reference is calculated as per age, height, gender, from where he or she belongs, either it is Australian, Indian, Caucasian, or American, whatever it is, we feel. Whether the person smokes, he or she doesn't smoke, smokes, how many packs, everything is we have to feed in the spirometer. So this is how we perform. The spirotechnician, he or she will explain the procedure to the person. We will apply a nose clip. We will apply the mouthpiece inside the spiral, and this should be fully covered. The mouthpiece should be fully covered with the mouth and fully covered with the lips, and this should be a closed circuit. There should not be any leakage from it. Now interpreting the spirometer. Anybody, just a wild guess. The most important thing in this stethoscope. No, in this stethoscope. I am asking in this stethoscope the most important thing. So I tell you, the most important thing in this stethoscope, the thing which is in between these two ears, that is our head. Okay? If you know, then only you can appreciate. Your eye will see, your ear will listen, if you know that thing. So this spirometry is just a tail for the diagnosis of either respective obstruction. The most important thing you should learn is history. History of the patient is the most important thing for all the person. So you just ask the history properly. These are all secondary things. Thank you. I rest you.
Thank you very much, sir, for this informative session. And with Dr. Dhan Ma'am, Dr. Vijayalakshmi Dhan Ma'am, who can today Dr. sir for this beautiful session.
If anybody has any question, they can personally interact with Dr. Deepak. He will be very gladly explain you, or whatever knowledge you want to gain from him, you can acquire.
Now we will be having a workshop on chest X-ray that will be given by Dr. Anshuman Mishra sir, IVS headquarters SECL, senior medical specialist radiologist. Dr. Mishra sir, workshop on chest X-ray.
तुम्हारा घर का उसको पढ़ाते नहीं हो क्या? वो सब वीडियो करके लेके किसको दिखाएगा? इसको देखना पड़ेगा है? अच्छा, लेकिन ना एक तो चीज समझाना है कि जो हम लोग को स्पायरोमेट्री कराता है उसको पहले ट्रेन करना पड़ता है, वो कैसे करके करेगा। बस ये तुमने मिसिंग किया। नहीं, वो करते जो करता है ना उसको सिखाना पड़ेगा जी हाउ विल। और तुम 3 बोला ना, जो 3 बार मोनोमेंट करना है, ये भी थोड़ा सा ज़्यादा होने से अच्छा है। मैं भी बोल रहा हूँ जी, जो टेक्नीशियन है ना उसको समझाना पड़ेगा जी कैसे लेना पड़ेगा, कैसे छोड़ना पड़ेगा।
So before we are diving into the topics presented in this conference by some of the heavyweights and stalwarts, myself Dr. Anshuman Mishra, radiologist at IVS Intra-Bihar Health Center, SECL headquarters Bilaspur. I am going to present just basics of reading a chest X-ray. Basically, as a practitioner, we are, all of us are encounter at least 5 to 10 chest X-rays daily. And the question always arises in our mind whether this radiograph is normal or abnormal. So in order to recognize abnormality, you need to know what a normal chest X-ray looks like. So before we start,
क्या भाई?
anything else, we must find out the extreme. That is how much black is black and how much white is white. Basically, काला कितना काला है, सफेद कितना सफेद है, वो हमको पता होना चाहिए. So the hierarchy of relative densities from least that is black to most that is white is black, less black than air, but it is a black water which is white or opaque or less lucent. Bone which is having the more opacity or more white than water, and any metallic object which is the most densest or the opaque object. जिसका भी हम रेडियोग्राफ देख रहे हैं, पेशेंट वही है, उसका ही रेडियोग्राफ है या किसी और का है. ऐसा नहीं होना चाहिए कि हम पहले किसी और का रेडियोग्राफ देख लें और पेशेंट कोई और देख. तो सबसे बेसिक जो है वो यही होता है कि हमको एक पेशेंट का इंफॉर्मेशन होना चाहिए कि हम उसी का रेडियोग्राफ देख रहे हैं. देन देयर आर वेरियस व्यूज इन द चेस्ट रेडियोग्राफ. Anterior view, lateral view, and lateral decubitus view. Most commonly used views are the posterior anterior and anterior posterior views. Then we have to examine, look for the whether X-ray is taken in deep inspiration or expiration, whether radiograph is in inspiration mode or the expiration mode. And we have to check the X-ray penetration, that is factors affecting the radiograph. Whether radiograph is underexposed or the over-penetrated radiograph. And last but most important thing is rotation of the radiograph. So there are four basic views of a chest radiograph: posterior anterior, anterior posterior, lateral and anterior. And in our day-to-day practice, we have most of the time we either encounter PA radiograph or AP radiograph. So what is the posterior anterior radiograph or the posterior anterior position? It is the most basic, most standard for obtaining a routine adult chest radiograph. In this position, patient chest wall is against the cassette or a film and X-ray is fixed on the back of the patient. Usually it is performed in a standing position with shoulders rotated forward enough to touch the film. And usually radiograph is taken in full installation. The next common position is the anterior-posterior radiograph or anterior-posterior position. This position is usually in ICU setup, that is patients who are debilitated, immobilized or position and his back is against the film or a cassette and X-ray beam is hit on the chest of the patient. So the three main factors that determine the quality of the radiograph are inspiration, whether patient is radiograph is taken in full inspiration or in partial inspiration, penetration of the X-ray beam, and rotation of a patient position. So in a good inspiratory film, we should look at the anterior ribs of a patient. And in a good radiograph, inspiratory radiograph, at least 5 anterior ribs should be visualized up to the diaphragmatic level. So this is a good inspiratory film. We'll look, these are the anterior ribs. And at least 5 anterior ribs, 1, 2, 3, 4, and 5 are visible. So this is a good inspiratory film. And similar for the expiratory film, at least 5 anterior ribs are visualized in a radiograph. Can you look the stark contrast difference between the inspiratory and expiratory film? What is the difference between inspiration and expiration? Can anyone? Deepak sir?
Hello. In inspiration, what we see is the airway. It is prominent, full airway. What we see, this cardiothoracic, costophrenic angle. It is seen clearly, and the lung marking is what we see. It is not so opaque, not so black. With the pointer, I would have told you. In this X-ray, it is whatever the thing it is outside this X-ray is black. That is air. The lung, what we can see is a gray type. It is because it has blood, it has airways, so it is little bit gray. And in expiration, you see the heart size, which should not comment. It is bit increased. The cardiophrenic and costophrenic angle, that is not visualized as clearly as it is in inspiration, and the air bronchogram, which is very prominent. So this is the difference between, and what we see is the rib counting. You start the rib from the first, second, third, fourth, that is laterally, till the end of 6.5 rib, it is inspiration. If it comes out to be 6 or 6.5 ribs, what we see from the backside to front, it is inspiratory. If we are not able to see the 6th rib,
sir,
such as in the second,
let me explain. Just the basic thing. अगर अच्छा इंस्पिरेटरी फिल्म है तो वो पूरा काला दिखेगा. क्यों? क्योंकि एयर को इनहेल कर लिया. एयर इज अ ल्यूसेंट ब्लैकेस्ट, तो लंग काला हो गया. एक्सहेल करेगा, एक्सपिरेटरी फिल्म होगी, तो एयर को उसने पूरा निकाल दिया, तो ऑब्वियसली लंग जो है वो वाइट हो जाएगा, ओपेक हो जाएगा. दिस इज द बेसिक डिफरेंस. और ज़्यादा आपने को कुछ भी नहीं देखना है. Next one is the penetration, the factors which decide the good quality radiograph. On a properly exposed chest radiograph, the lower thoracic vertebrae should be visible through the heart, and the bronchovascular structures behind the heart should be seen. While an underexposed chest radiograph, the cardiac shadow is opaque with little or no visibility of the thoracic vertebrae. Lung may appear much denser or whiter given the appearance of infiltrates. So this is the overexposed or over-penetrated radiograph, and this is the under-penetrated radiograph. In case of over-penetrated radiograph, we see the thoracic vertebrae, clearly seen the thoracic vertebrae, while in the under-penetrated radiograph or underexposed radiograph, the vertebral bodies are not seen. And the next most important thing is the rotation. The patient rotation can be assessed by observing the clavicular heads and determining whether they are equal distance from the spinous process of the thoracic vertebral bodies. So in a normal positioned radiograph,
both clavicles are equidistant from the spinous process. If the patient is not rotated, the spinous process is in the middle of the thoracic vertebrae, and both the medial ends of the clavicle have equal distance between the with the spinous process. So basically, there is a general principle for an approach to report a radiograph. First, we have to develop a systematic approach to read a radiograph and always interpret the findings of the radiography or correlate the findings of radiography with the clinical findings. And if you have a privilege of comparing the X-rays with previous radiograph, always consider that and always ask yourself, does my interpretation make sense? The basic approach for the X-ray is the ABCDE, where we look at the adequacy. A is for the adequacy, alignment, and the airway. Look at the bones and the soft tissues. Look at the cardiac shadow, heart borders, diaphragms, and everything else, that is rest of other things which are visualized in a chest radiograph. Now the adequacy is first to look, decide whether this is a PA radiograph or AP radiograph, and decide whether it is a properly exposed or overexposed or underexposed radiograph, and decide the rotation of the radiograph. Can you see? Can you say this is the rotated or the normally midline radiograph? This is a rotated one because the spinous process, look at this, these are the spinous process, and the distance between the medial ends of the clavicle are not equal. This side is less and this is greater distance. Next is the alignment. So the trachea should be centered between the clavicles. Look at the clavicles. So trachea is in the midline, and look at the division of the trachea for the right and left bronchus. Next is the lungs. Basically, lungs, right and left lung is divided into lobes. Right lung have 3 lobes and left lung have 2 lobes and a lingula. But in chest radiograph, we do not, in a chest radiograph, we divide the lung into the zones, not in the lobes. And lungs are divided into the 3 zones, upper, mid, and lower. So how to divide the lungs into the upper zone, mid zone, and lower zone? These 2 lines, A and B, these 2 horizontal lines are passing through the upper pole and the lower pole of the hilum. These are the hilum of the lung. So the one horizontal line passes through the upper hilum and one horizontal line is passing through the lower hilum. So the lung above the line A representing the upper zone, in between the line A and B is the mid zone, and inferior to line B is the lower zone. Next is the look at the heart or mediastinum. So this is the cardiac silhouette or the cardiac shadow. This is the left heart border, this is the right heart border. And heart should occupy at least less than or at least 50% of the internal thoracic diameter. Anything ratio, so we calculate the cardiothoracic ratio. That is the distance between the CP angles and distance between the cardiophrenic angle. And if this ratio is more than 50%, then we say that it is a cardiomegaly. Now look at the diaphragm. Diaphragm should be a sharp margin with lateral chest wall and contours of the diaphragm, that is the medial side of the diaphragm should be always upward than the lateral half of the diaphragm. Look at the surrounding soft tissue. Like in this case, there is air under diaphragm. Always see the surrounding soft tissues, supraclavicular region and at the diaphragm level. This is a case of surgical emphysema, where the air or gas is accumulated in the subcutaneous tissue. So subcutaneous tissue and bones are, soft tissues and bones are very important in a normal chest radiograph. ऐसा नहीं है कि हम सिर्फ chest को देखे, lungs को देखा और उसके बाद छोड़ दिया. We have to look for the surrounding supporting structures also. Look at the bones, count the ribs, look for any accessory ribs or the bony abnormality, bony fractures or the hypoplastic ribs or the any other bony anomalies. Can you see, look at the fractures, anterior ribs or posterior ribs? This X-ray represents the fracture of the anterior ribs. Posterior ribs on right side. Next is the look for the lines and metal work for such as the sternal wires, tip of endotracheal tube or the central lines. Like this X-ray represents the sternal sutures in midline. This X-ray represents the central venous catheter. And look at the position of the central venous catheter. It should be end at the above at the origin of superior vena cava. Now, how would you summarize this radiograph? Can anyone? Is it normal or abnormal? Any pathology? Any pathological findings? Look at the lungs. Lungs are clear. CP angles are clear, no evidence of pleural effusion. Lung contours are well maintained, left heart border and right heart border. Bones are normal. So this is a normal chest radiograph. Now the basic lung patterns of lung disease. Basically, we encounter 4 patterns of lung pathology in chest radiograph. First is consolidation. where any pathological process that fills the alveoli with fluid, pus, blood cells, and other substances, resulting into the lobar or diffuse multifocal ill-defined opacities. Second one is the interstitial lung disease, where supporting tissue of the lung parenchyma result in fine or coarse reticular pattern. Third one is the nodule or mass, that is the space-occupying lesion. And fourth is the atelectasis or the collapse of the lung segment. So this is the diagrammatic representation of the lung pathology. Consolidation, where the normal air-filled alveoli are replaced by the pus cells or fluid or blood or any solid substances. Nodule or mass, these are the space-occupying lesion. Atelectasis or collapsed lung is the loss of volume of lung volume. And interstitial pattern, where the lung parenchyma is replaced by the reticular opacities. So this is the radiograph taken in a ICU setup. This radiograph shows the diffuse consolidation, which is consistent with the pneumonia. This is a case with a patient with a history of CA breast. Can anyone notice the abnormality here?
Post-MRM, left-sided.
Yes, yes. Left breast shadow is not visible here as the right breast shadow is visible. Other than this, everything is normal. Can you look at any abnormality in this radiograph? Yes, fracture right clavicle. Any findings? Consolidation. Multilobar consolidation. Multifocal consolidation. Area of patchy, area of opacity in left mid-lung zone and, right mid-lung zone and left upper lung zone. Any abnormality? Pleural effusion, right CP angle is visible, left CP angle is blunted. Pathology.
Sir, left upper lobe consolidation. SOL, space occupying lesion.
Space occupying lesion, lung mass basically. Yes, sir? No. Proven case of lung mass. CA lung. Any abnormality?
Left-sided pneumothorax.
Yes. Any questions? Chale.
Thank you, sir. I now request Dr. Kumudini Xavier, ma'am, CMS Korba area, to felicitate Dr. Anshuman, sir. next session. I request Dr. C. Pavan Kumar, Deputy MS Korba, SECL, to present on ILO radiographs and pneumoconiosis.
Check. Sabhai Namaha, Gurubhyo Namaha. Myself, Dr. C. Pavan Kumar, statutorily certified in AFIH, RLIC, then X-ray, ILO reader, and also guest faculty for Central Labour Institute, DG Fastly, and also certified medical auditor, Mines, ISM, IIT Dhanbad. Thank you. Today, we will try to see the basic of pneumoconiosis and ILO radiograph reporting. So, coming to the pneumoconiosis, what is pneumoconiosis? Pneumoconiosis per se is the dust in lungs. Dust in lungs. So, it is the lodgement of any inhaled dust. So, the dust which you can inhale, which can enter till the level of your alveoli, if the dust can enter there, then it may come under pneumoconiosis. So basically this pneumoconiosis is a notifiable disease. What is the meaning of notifiable? Notifiable means we are informing to n number of authorities, including the highest level of authority. So it is completely transparent. So before we are understanding what is the actual meaning of transparency, so the notification, the term has arrived, and everybody will come to know that something is happening here. So pneumoconiosis is one of the notifiable disease under Mines Act and rules. So here pneumoconiosis, it is definitely not asthma. If it is diagnosed as asthma, then it is not pneumoconiosis. If it is been under the care of pulmonary physician, then it is definitely not pneumoconiosis. If it is neoplasia, then it is definitely not pneumoconiosis. So that exclusion is very much required. So here, the diagnosis of pneumoconiosis is mostly like exclusion. First of all, you exclude each and everything. Exclude each and everything. 2 times, 3 times. So this will come from the area level or unit level, then area level, then headquarter level, then even DGMS also will keep a board. We are having a DGMS certified pneumoconiosis board. It is right now there. In 2022, the Gazette notification is there. Our ECL doctors are the members in the pneumoconiosis board. So that is the certified pneumoconiosis board from DGMS Dhanbad. So what will happen in pneumoconiosis? It will transform into collagenous opacity. There is an opacity. The opacity will happen. So who can cause it? If the dust is respirable, if the dust particle, if it can enter into the lowest of the lowest airway, that is your alveoli, if it is able to enter into your respirable airway, then it can cause the damage. So the pathology is definitely not due to the inhaled dust. Most of the time, whatever the particle is entering into your body will not cause the disease, most of the time. The disease is due to the pathology, or the inflammation, which is mounted against your dust, will cause the damage. In other words, our own immune system will be is the causative factor for pneumoconiosis, as per a definition. So, we already know these things. What are the different things? These are, I am not able to explain each and everything here. So, diagnosis, the precipitous deterioration. The patient will deteriorate like anything. So, deterioration, how it will be understood? It will be understood by the respiratory capacities. So, today we have already seen what are the different lung capacities, FEV1, FEVC, the precipitous deterioration within 6 months, within 1 month, the lung volumes will come down like anything. So that type of deterioration, the functional deterioration will happen. And the knowledge of pneumoconiosis, so as the previous speaker said, if we know, if we can see, if we only have the knowledge, then only we can diagnose the pneumoconiosis. So history of occupational exposure, 100%, 100%. The first and foremost important thing is occupational exposure. So who will get pneumoconiosis? Only employee. Who is employee? As per the statute. Whatever the employee is defined as per the statute, if he is an employee, then only I will try to say whether it is a pneumoconiosis or not. If he is not employee, I am not at all worried whether this is pneumoconiosis or not. If I am a regular worker, I am working at somewhere else. If I am driving on the road, if I am getting this type of features, no, I cannot claim the pneumoconiosis. Where I should go? So that is not there as per the extant rules on date. Okay. So due to the environmental pollution, if you are getting something, a feature of pneumoconiosis, no, it's not at all a pneumoconiosis. Pneumoconiosis is only for employee as per the extant rules. So radiological findings, there are some specific radiological findings will be there. If only there, then only we can think of pneumoconiosis. Functional parameters of respiratory system. So that is nothing but the lung volumes. Very, very important. Lung volumes or the spirometer readings are very important. They will play vital role in understanding each and every parameters of pneumoconiosis, including the compensation also. High index of suspicion. You have to suspect, yes, this person. When you will suspect? When you will understand where actually this person is working. Whether this person is working at the office room, whether this person is working at the coal face, underground, coal face, young person, if he is working, if he is having a cough, then you have to have high index of suspicion. It's very much required. Exclusion of pathology, 100%. I have to repeat it like 100 times. If I'm having enough time, I will repeat only one term. Exclude, exclude, exclude all pathology. Unit level, area level, headquarter level, Coal India headquarter level, even DGMS also, once again will exclude. Once again he will call the physician and respiratory physician, and he will again and again, repeatedly, we have to exclude. Then why this much important? Why this much? Why this lecture has to be taken for 30 minutes or 3 days? So there is no satisfactory curative treatment. There is no treatment at all. Zero treatment. So if there is zero treatment, what have to do? So they require something in the, for example, they are giving their life. They are giving their productive years of life. By giving the product, you are getting the benefit. We, the employer, getting the benefit from the employee. In turn, we have to give something. So maybe to understand, to give that something, we have to have the base knowledge of pneumoconiosis. Drugs, physiotherapy, transplant, whatever you say, are not at all satisfactory. Very poor prognosis. If it is fibrotic, nothing else we can do. So coming to the, I am giving very short notes of the each and every disease, very short notes. Asbestosis. Asbestosis, we know there is something called ferruginous bodies are there. These ferruginous bodies are there. Then we may say that it is an asbestosis. Pathognomonic, the most dangerous particle type is crocidolite variety. And the asbestosis, what is the specialty of this asbestos? Asbestos, the specialty, these are fibers. These are very sharp fibers. You can see here, these are sharp fibers, very sharp. They are the two-edged sword. They are having a edge on this side and also this side. If I am inhaling the fiber, what will happen? The fiber will traverse your fibrotic layers. That is nothing but coelom. You are having one coelom in your lung and one coelom cavity in your mediastinum and your one coelom in your pleural fluid, pleural cavity, peritoneal cavity, mediastinal cavity. So these sharp fibers will traverse through your cavities. Transcoelomic spread. That is the beauty of the asbestos fibers. They don't have any borders. They will move like anything. They can go anywhere and they can cause the damage. That is the beauty of the asbestos fibers. So complicated with restrictive disease. They can go for a transmigration, transperitoneal, transcoelomic spread. So the problem with this type of asbestosis, they are having mimickers. It looks like idiopathic pulmonary fibrosis. It looks like secondary metastasis, hemopyothorax, cardiac disease, due to some features which are actually in relation with the said diseases. So exclusion, exclusion, exclusion. 100% you have to exclude. The cardiac specialist has to see, the physician has to see, and the cancer specialist has to see, yes, this is not cancer, this is not cardiac disease. Then they will pass to the occupational health physician. Then only the occupational health physician will take a decision. Then who will get? So we are having the occupational exposure. Which occupations? Old coal mine. Just imagine that there is a old coal mine in your subsidiary. They are having brake linings. In the brakes, the beauty of the asbestos fibers, they are having the very beautiful physical properties, chemical properties. They can withstand high temperature, high pressure, high stress and strain. For that reason, and also very cheap, very cheap, very cheap. For that reason, these fiber had been used at n number of areas, n number of areas. So like, for example, you can see, these are the brake linings, very cheap item. So this is the fireproof blanket, fireproof blanket. So fireproof blankets, brake linings, clutches. If you are having any old mine, you have to suspect, yes, there may be a chance of asbestosis in this particular person if he is working at that particular place. So we have to understand, we have to relate with the hazard location and the working person, exposure, years of exposure, then the radiological findings. So this is the CT scan. And coming to the silicosis. What is the beauty of the silicosis? Silicosis, freshly fractured silica. There is one term called as freshly fractured silica. One more thing is free silica, free silica. Free silica, freshly fractured silica. For example, just imagine that this is the silica molecule, a quartz molecule. It is a molecule of a silica, one compound is there. If I am just breaking it, if I am just breaking the molecule, what will happen? The breaking, the surface which had been broken out, those are called as freshly fractured silica. Freshly, just now it has been broken. They are very much reactive. They are very much reactive. They will generate reactive oxygen species. They will generate reactive oxygen species. They are the cause of the damage. Freshly fractured. Just now it has been fractured. One. And for example, free silica. What is the meaning of free silica? The silica which is ready to react. It is very much aggressive, like nascent oxygen. The type of reaction is there, nascent oxygen H2O2, you will have the nascent oxygen, freshly prepared oxygen. It is very much reactive. It will clear the damage. So like that, freshly fractured silica and the free silica are more dangerous. So, hazard location, coal face. So whoever is working underground at the coal face and the surface coal face, roof bolting. So here we will understand what is the meaning of the coal face. For example, you can see this is the continuous miner. So there are high wall, low wall minings, and high minings and low minings. This is a continuous miner. It is taken from internet from the China. But it is, this similar type of machines are there in our underground also. I had visited so many underground mines which I am not allowed to take any photograph. So this type of machines are there in our underground mines also. We are using them. While it is breaking the coal face, what will happen? The silica is breaking actively silica is breaking. So there is a research done by CIMFR, CSIR, Dhanbad in 2010-2011 on Coal India and its mines, and it has classified the mines present in our subsidiary, sister concerns, and it had said that, for example, if you take the WCL, it is having 2 mines which is having more high free silica content. 10% of silica content is there. So there is a study actually, which is done on our Coal India and its sister concerns only. So we are having silica content, yes, we are having high silica content. So we have to understand what are the operations. There is a roof bolting. So this type of roof bolting we can see in underground mines to keep the roof safe. It's sure that it should not fall on us, roof bolting. So this is the crusher, very big coal pieces will be kept here and they will be made into powder. And this is the continuous miner, and this is the roof bolt zoomed image. So those people who are working near these locations, you have to keep a suspicion that these persons may have silicosis. So these are all the work locations which has been given by the CIMFR, CSIR, Dhanbad 2010-2011 research done on Coal India and its system concerns. And coming to there are something called as tuberculosis. This tuberculosis, which is present all over our India with a prevalence of 33%, if this tuberculosis is also working along with our pneumoconiosis, it will definitely complicate. So that is the problem, silicotuberculosis. So in silicosis, you will have egg cell calcification, coal workers pneumoconiosis. Coal workers pneumoconiosis is nothing but silicosis plus coal. You will be having more amount of coal and a little bit amount of silica. So it is more or like, for me, it looks like a silicosis only feature. So there is something called as rapidly progressive coal workers pneumoconiosis. We don't have adequate time for this. So now we will start with the ILO radiograph digital standard, which is replacing 2011 D version of ILO radiograph guidelines. So I think everybody is having the sheet of the ILO radiograph paper. Please, if you are interested, please try to open that paper and please try to fill it. Thank you. So there are guidelines, DGMS. DGMS is the statutory body. Statutory, what is statutory? Statutory is equal to if something is written in the act, ACT, Act. अगर कानून में ये है, तो ये कानून का अंतर्गत. If it is there in the act, then it is called as statutory. So there is a thing called as DGMS, which is the statutory body. If it is releasing something, then it is having the power as a statute. So in 2007, 11th of June, they had given guidelines how to maintain your X-ray viewing boxes. How should you have to maintain the X-ray viewing boxes? So X-ray viewing boxes, how should be there? So your viewing box should to accommodate four X-ray at one time. At one time you have to view 4 X-ray. So those are 14 by 17 inch of size. 14 by 17 inch of size. So there are some guidelines already given in DGMS. So DGMS has clearly mentioned where you will find the original hard copy. In the same year, on the same date, they had mentioned the address. But as of now, it is not available. As of now, we are not getting any hard copy images of ILO X-ray images. No. Those who are already having, they can do. Those who are not having, they cannot do. Then, coming to the introduction. Why ILO X-ray standard? Why standard? Why standard? The guideline is there. You have to wear the blue shirt and some black pant. This is the standard. Every coal has to wear this. This is the standard. There is no logic. In standard, basically there will be no logic. After keeping the standard, we can use some logic. So the logic is, everybody please wear blue shirt and black pant. This is the standard, basic understanding. Standard, why we are keeping? So here, whatever we are going to discuss, these are not pathognomonic. No. These are not pathologically related. These are not pathological entity. And mainly, principally, these are not working capacity. ILO images, ILO standard, if I am saying 1/0, 2/0, it is not defining the working capacity. Working capacity principally will be decided by the spirometry and any other tools which are maybe decided by the pulmonologist, but not by the ILO standard. And it is not definitely for the compensation. No, you may not please be decide compensation based upon the ILO images. This is the standard given by the ILO. Yes, it is for epidemiological screening. So what is in your India, in the Maharashtra or in the Madhya Pradesh, how much 1/0 is there, 2/0 is there, P/P, just to get a understanding. Screening, comparability. I want to compare with ECL with MCL. So how many 1/0 or 2/0 is there? Just for comparing, just for surveillance, screening. So we will try to understand. Basically, we are now very slowly, or we are turning into the digital mode. Everything is turning into digital mode. So we will try to understand what actually is a digital X-ray. So just to try to understand, this is our conventional X-ray. Conventional X-ray machine will be there. Then here is the patient, subject. Then there is a processor. Then you will do processing, manual processing, developing, fixing with 22F medical grade. then you are preparing the hard copy. That is the old model. Now what we are doing? Same old X-ray. Just keep the old X-ray machine. There is no need to buy new X-ray machine. Keep the same age old X-ray machine. X-ray machine is same. Just what we have to do? You can buy a scanner. There is a scanner is available, and we have to buy cassette. Cassette we have to buy. Scanning machine we have to buy. Then if you are doing this thing, then what it will called as CR, computerized radiography, CR. If you don't want to buy scanner, so don't buy the scanner. Just take a different type of cassette. Directly it will send the image to your X-ray machine, X-ray processing thing. Then directly the digital processing will be there. Then this is called as a DR. DR is called as direct radiography. Direct radiography. Direct radiography and computerized radiography. There are two types of radiography, CR, DR. In CR, you will have scanning machine separately. In DR, there is no scanning. No scanning. Directly, the image will come. So, as per the DGMS guidelines, we are already directed to use the digital radiography. If you are ready, please start it. So, we will try to see, there is something called as PACS. There is something called as PACS, Picture Archiving and Communication System. We will try to understand is what is PACS. PACS, it is already there in most of the HIMS second phase hospitals. What is PACS? First of all, there is a registration department. This is the registration. Just the patient is coming to you, the patient is registering. Age, C. Pavan Kumar, 34 years, male, for annual medical examination. Am I clear? Up to here, please try to hear. Registration desk. Then what will happen? Then I will go to the X-ray. Then I will go to the X-ray room. Then I am getting the X-ray. I am getting the X-ray. Then this X-ray will be feeding into a laptop. Just imagine there is a personal computer. One big computer is there in the X-ray room. So this image is going into the X-ray room computer. So this is PC in the radiology department. Up to here is, I think it's clear. Then what will happen? I will keep a very big memory card, very big hard disk with an individual power supply. Then I will call it as archive. The name is archive. Archive, what is archive? It is a very big hard disk with an individual power supply. It is an archive. Okay, very big hard disk. Then what I will do? In the radiologist, our radiologist or the AFIH, occupational health physician, is seeing the X-ray, we keeping in the hospital, within the hospital. Just say, I am from the main hospital Korba. In the main hospital Korba, the X-ray, whatever the X-ray is coming into the OHC department, by sitting in the OHC department, if the doctor is seeing, this is the radiology workstation. Radiologist viewing the PC. Then what will happen? So not only main hospital Korba, everybody has to see. Then what I will do? I will connect to the internet. This server, what is this one? This is the PC which is kept in the radiology X-ray room. I am connecting with an internet. So this is not a normal internet, this is a tunneled internet. What is tunneled internet? Internet, for example, this is the internet, this is the root internet. I will go like this. Okay, very secretly I will go. So this is called as a secret network. Within the internet, I will keep a tunnel. It is a very secret route I will go through so that everybody cannot see. I am using the internet, but everybody cannot see. To see me, they have to use the address. So that is called as a tunneling. So we in Coal India, we use Railtel internet and we use MPLS. MPLS is a secret tunnel. Nobody can see, only few people can have the access. So in this tunnel, other hospital, if I am sending my X-ray from SECL to WCL for expert opinion, I can send. So this is otherwise the PACS. This is the simple architecture of a PACS. This is picture archiving and communication system. Then what is required now? PACS is done. Now what I need? I need DICOM. What is DICOM? DICOM is simply a software. It is nothing like that. It is just a software. So this software, while I am acquiring image from X-ray, I have to use the software. While I am seeing the X-ray, I have to use. While I am sending into the memory card, I have to use the same software. Into the internet, while seeing also. At everywhere, at every location, I have to use the software separately. separately I have to use. So this is the DICOM enabled packs. DICOM ho gaya, packs ho gaya. Dono you have to merge. So that is the recommendation. I think it is clear, DICOM and packs integration. Am I clear? So the standard guidelines, what it is saying, you have to use a 4 X-ray viewing board. So this is the normal board which is present most of the locations within the OHCs. So you can use the hard copy ILO X-ray. So this is one of the OHC within WCL, Rajiv Ratan Central Hospital WCL. So they are keeping this 4 X-ray viewing board. So this is for an example I am just showing. Am I clear? So this is the software which we'll be using. So there is not enough time to open the software. When you open the software, it will look like this. This is an user interface. So in this user interface only, this is the software where you can see. This is the DICOM software. So in this software, you can have measurements, length. You can see the length, you can see the volume, you can see the every measurements, different types of measurements you can see within the DICOM based upon your type of software. So DICOM software is recommended by ILO. So hard copy, what is the difference between hard copy and soft copy? What is hard copy? Hard copy means the hard copy X-ray film which is provided by the standard institute. It's not printed item. You cannot print it at your own hospital. If you are printing in your hospital, if you are using it, it is against the statute. It is against the statute. It is not at all recommended. You have to use the film which is being provided by them only. If it is not there, then don't go for hard copy. You have to use only soft copy. So what is soft copy? You have to use soft copy only in DICOM format, not JPEG format. So just keeping the soft copy in your mobile, laptop, it is not at all recommended. It is not at all recommended. So we will try to fill the form. This is the form which is given to you. So it will be having this type of format. And first of all, we will see the technical quality. Time is very short. I will try to take little bit amount of time. Sorry for that. So first of all, technical quality. So you are having an X-ray film. You are having the X-ray film. Just imagine that you are having a hard copy X-ray film. Okay. So whether it is good, acceptable. What is the technical defect? What is the meaning of technical defect? It is written here. So these are the technical defects. If it is overexposed, underexposed, artifact, poor processing, poor contrast, improper position, underinflation. If there is any artifact, then it is called as a technical defect. If there is a technical defect, you have to mention. Even if there is a technical defect, whether you are confident, yes, I have to grade it, then you can give the ranking like this. So if it is good means, it is not at all having any technical defect, 0 technical defect. Very beautiful X-ray. Very beautiful X-ray, PA view, deep inspiration. PA view, deep inspiration, very beautiful X-ray, then it is good. It is PA view, but little bit artifacts are there. If it is PA view, if there is little artifacts are there, you have to mention it. Then it is not acceptable. It is not at all a PA view. It is a AP view. It is expiration. Then it is, you have to discard the same. So here, while taking this, just I am writing the name, for example, Raju Robert. If anybody wants to write, please write any name, and the patient ID, and then the birth date, and the radiograph date. Just imagine that today the radiograph was being taken. So just I am taking that the image quality is grade 3. Grade 3 means what? It is having so many artifacts. It is having some artifacts, some problem is there. So what artifacts are there? It is overexposed. There is having something called a scapular overlay. We will see what is scapular overlay. If you are able to see the scapular margin within the lung markings, then it is called a scapular overlay. Then the film, which is actually hard copy, the patient had folded it. The patient folded it to keep it in his pocket. So just imagine the film being folded in half. So that's it. That is the section 1 is completed. So then coming to the lung zones. So for the ILO classification, they had divided into 3 zones. Upper zone, middle zone and lower zone. Then coming to the profusion. What is the meaning of profusion? Profusion is nothing but number, only number. It is numerical. Number. How many number of opacities are there? It is not about the size, number. So how many number, how you will say? With the standard radiograph. You are just keeping the standard radiograph here and you are seeing whether the same number is present or not. For example, in the 1 by 1, so this is the X-rays, different standard X-rays. Just keep your patient X-ray here, just to try to see these number of opacities, whether it is present in the patient X-ray or not. If you are feeling the same number of opacities are present in 2 by 2 are present in your patient X-ray, mostly. And you are also having a doubt whether it may come under 1 by 1 also. So whatever the dominant number, it will be 2, and the less dominant will come as 1. So that will be 2 by 1. Just imagine, is there any classifiable parenchymal abnormalities? Yes. Then where you are feeling there is an opacity, just imagine that your middle, right zone, in the right zone, in the middle zone we are having the opacity. And then in the left upper zone we are having the opacity. Left upper and right middle. So just I am thinking that secondarily there is a size. So coming to the size, based upon this size. Thank you.
You can carry on for 5 minutes. Carry on, Pawan. Just give us the numberings.
Okay, sir. Flow band ho gaya, sir. Okay. So, first of all, we had seen the number of opacities. The number is defined in 1, 0, 1 and 2. 0, 1, 2 is for the profusion. Profusion is equal to number of opacities. Profusion is equal to number of opacities. And then coming to the size. Coming to the size, there are two types of shapes. First of all, you have to see the shape, whether it is regular rounded opacity or irregular opacity. Irregular opacities are always dangerous, mostly. So if I see the SRB textbook of surgery, so it is written in the breast, if it is an irregular spiculated opacity, just query CA breast. So that is what my understanding. Maybe due to that, they had classified the irregular opacities on one side, regular opacities on one side. So they had given two types of thing, PQR, STU. So there are two separate classifications are there based upon the size. Similarly, for the shape, if the size is of large size, they had given the size of ABC. ABC. So this is the size of the A, and there is one more size of B. Based upon this size, it is numerical value as per the guideline. Then coming to the plural opacities. Plural opacities, it is little bit, we have to give a little bit time. So plural opacities are basically three things, meaning basically minimum. One is N phase A, one is in profile, third one is CP angle. What is N phase A? N phase A means it is facing towards you. It is on anterior surface. For example, my coat. If I am having a mark on my coat, that is a N phase A. If I am having a stain, on my coat, it is an N phase A stain. If I am having a stain at my armpit due to sweating, if I am having a stain, then I will call it as in profile. Just try to remember, this is in profile. So if my CP angle is obliterated, that is one type. So these three things, just try to remember. So with this, I would like to close my ILO radiographs with pneumoconiosis concept. Thank you for this opportunity. Thank you.
Thank you, Dr. Pawan, for a nice deliberation of ILO radiography. All people who are doing IMEs and PMEs, If you want to take any information or instruction from Dr. Pavan, you are free to interact with him during the break. He will explain you with beautiful, you can see his lectures, how he speaks. Thank you.
Thank you, Dr. Pavan Kumar, sir, for this powerful and informative session on ILO radiographs and pneumococcus. Now request Dr. Ashok Sharma, sir, ex-CMS SECL, to felicitate Dr. Pavan Kumar, sir, for this powerful session. Further, we have another session on what we must know in IME and PME by Dr. Debashish Negoi, sir, ex-CMO WCL. Sir, we'd like to hear you.
Good afternoon all. Myself, Dr. Debashish Neogi, ex-CMO, Western Coalfield Limited. I have just changed the topic to statutory compliance of IME and PME in coal mines. It's okay. Thank you. In my PPT, I'll just limit myself to these following contents. As a legal framework, what is IME? What are the amendments of medical attendance rules? The forms and annexes, PME and other medical examinations, statutory examinations, and conclusion. First and foremost, we, the doctors of Coal India, are posted at remote locations, and we do not have any induction training like that of the management trainees. So during our tenure in the earlier life, we doctors of CIL are always exposed to initial medical examination or maybe periodical medical examination. Thank you. Since we do not have any induction training, we learn the nitty-gritty by exposing ourselves, or rather experiencing in the due course of time. As you all know, that conducting initial medical examination and the periodical medical examination is not the domain of the occupational health center. Usually what happens, whenever a candidate lands up in a hospital for his initial medical examination, the in charge of that unit or hospital marks that file to the concerned OHC unit for his initial medical examination. Now, as per the Coal India role profile, which has been reviewed in 2018, 2020, and also the latest one, 2024, all medical executives whether you are located at the headquarters or at remote locations like a dispensary or the area or regional hospitals, or in whichever designation you are in, this statutory medical examination is one of our tasks, which is also included in the CR or the PAR that we need to fill up every year. First and foremost, we need to know what is an act and what is the difference between an act and a rule. Formal laws, which are set by legislative bodies, is called an act. And a rule provides us a more further specified instructions and further guidelines for implementation of that act. So acts are passed by legislative bodies and rules are framed for implementation of that act. Now the governing laws and authorities, the Mines Act 1952, the Coal Mines Regulation 2017, the DGMS, the Directorate General of Mine Safety, and the Coal India Medical Attendance Rule, which is an internal policy. This is a snapshot of the Form M. This is the notice for initial and periodical medical examination that a manager of a mine is supposed to pass on to the candidate who is due for his initial medical examination or periodical medical examination. This is the first notice, and he is given a time period of 20 days to get his medical examination completed. A copy of the same is also sent to the examining authority. Now, if the person fails to attend for his initial medical examination or PME at the center, he is given another chance. That is in Form N. And again, a time period of 10 days is given for conducting the same. And if that person fails to land up for his examination, he may be discharged from the service if he is unable to provide suitable justification, which needs to be approved by the manager of the mine. What is initial medical examination? It's a health assessment carried out before the job placement of workers or their assignment to specific tasks which may involve danger to their health or that of others. Whenever a person is exposed in a workplace, he is exposed to both physical, chemical, psychosocial and biological factors. These may affect his health. The statutory requirement: no person shall be employed in a mine unless he or she has undergone IME, declared medically fit, conducted by a qualified medical officer. Now, as per Medical Attendance Rule of Coal India Limited, the IME can be conducted by a single qualified medical officer of the company, or a board may be set up consisting of a number of medical examiners, which is approved by the CMO of that hospital. The fitness certificate is mandatory before deployment. The compliance essentials, the identity and age verification, the baseline health documentation, and the work-specific fitness categorization. Now its applicability and the legal framework. We know in Chapter 8 the rules related to medical examination, that is Medical Attendance Rule, CIL, and also the Mines Rule 1955, that is Chapter 4A as per 29BA, the medical standards of fitness as per Form PI. Now, if there is any confusion or ambiguity, we have to refer to Mines Rule 1955, and the circular has been issued by Coal India, dated 14/4/2016. I'll be showing you the snapshot. Now, the IME of contractual apprentice, the PGPT and PDPT, we need to follow the standards in Mines Rule 1955, that is set in Chapter 4A. This is the Form I, the standards that we need to follow. This is the circular. This is an important circular. And it is clearly written that it was decided that in any case of disputed nature under IME, it may be dealt as per the Mines rule. Subsequently, 2 amendments were brought out, one in the year 2022, that is August 22, and the other one is March 2025. In the first amendment, it was regarding blood sugar. Earlier, we used to measure only urine. In initial medical examination, we used to record the urine sugar or albumin. And in the 10th Safety Committee guidelines, both fasting blood sugar and the postprandial blood sugar were also included. Now, candidates suffering from diabetes without any organ damage will be considered fit for employment. This was one of the amendments that came out in August 2022. The next amendment was on blood pressure. Candidates suffering from blood pressure, which is not considered as severe hypertension, that is equal to systolic blood pressure equal to or more than 180 millimeter of mercury, or diastolic blood pressure equal to or more than 110 millimeter of mercury. They can be declared fit if there is no organ damage. And the third one was regarding color blindness. All employees are to be examined for color blindness. However, the color blindness will be acceptable for employment under Group B. In the subsequent slide, I have given an example. We received, in Western Coalfield Limited, we had received numerous representations by different political institutions. In one case, a mining sardar who was declared unfit because since he was colorblind, and we received numerous representation even from the Prime Minister's portal also, that since your medical attendance rule amendment already says that he should be examined at Group B, he should have been given a job under Group B. Because mining sardar is a mining discipline and it comes under Group A. He cannot be made fit under Group B. So we asked for we raised a query to Coal India, and Coal India replied that relaxation for color blindness is permissible only for those employments which do not fall under Group A of medical attendance rule. Mining sardar is employment belonging to mining discipline, which is employment under Group A of MAR. The latest amendment came in the year 2025, and it was regarding the height. Earlier, for the specific tribal category like the Gorkhas, Garhwalis, or the Assamese tribal, the height had been relaxed to 60 inches. Now, the amended provision said that the minimum standard for height in Group A, for men it was 60 inches or 152.4 centimeter, and for female it was 147 centimeter or 4 feet 8 inches. And it was relaxed by 5 centimeter for both male and female for Garhwalis, Gorkhas, and Assamese tribals. For Group B, the minimum height required for males was 147 centimeter or 4 feet 8 inches, and for females it was 142 centimeter or 4 feet 6 inches. And for the specific tribal group, that is the Gorkhas, Garhwalis, and Assamese tribal, for males it was relaxed by 5 centimeter, and for females it was relaxed by 2.5 centimeter. But it is also important to note, for the post and disciplines where the medical or physical standards are already mentioned in the cadre discipline, we have to take that in. Now, this is the amendments in cadre scheme for security discipline. In the security discipline, it has been emphasized there are broadly mainly 2 parts. There is the weight of the a person should not be grossly overweight or grossly underweight. And they have given a capping of BMI from 19 to 27.5. It should be between 19 to 27.5. And for the height, they have uniformly said that all cases of security guard, whether it is male or female, the minimum height required should be 152 centimeter. And you are not supposed to take up colorblind person as security guard or epileptic person as security guard. Now, the next part, we have conducted the medical examination. Now, where do we document it? As per the 29F of Mines Rules 1955, the details of medical examination has to be recorded on Form O in triplicate. On completion of examination, a copy of the medical certificate in Form O shall be issued by the examining authority to the person concerned by registered post or delivered under receipt, and another copy sent to the manager of the mine concerned by registered post or delivered under receipt. The examining authority shall retain the third copy of the medical certificate. Now, this is very important. Usually what happens is, we conduct the medical examination on Form O, and we send 2 copies to the office of the HR, and we retain the third copy with us. I think most of us who are here will agree with me. And we generally, or rather usually, we do not hand over the candidate's copy. So what happens is there is a provision in Mines Rule under 29J and K for medical examination by Appellate Medical Board. If a candidate is made medically unfit, he can apply within a span of 30 days for a medical re-examination by Appellate Medical Board. Now, what the Appellate Medical Board requires? It requires that the application by the candidate should reach via the manager of the mine to that office of Directorate General within 30 days span, and the application should also have an attached copy of the last Form O. Many a times it has been found, and DGMS or the Chief Inspector of Mines, while visiting our hospitals, have again and again reiterated that since you did not give a copy of that medical fitness to that person was denied medical re-examination by the Appellate Medical Board, which is violation of the Mines Rule. So we need to be very careful. We have received many such violations in our Western Coalfield Limited also from the DGMS. Lastly, who was Dr. Sarkar was there, DGMS there in the Western Zone. And he time and again he reiterated that you are missing this thing. This is the copy of Form O. Year before last and in the 2024, I had been traveling across different central hospitals for the medical audit. And there was a huge difference in the Form O that was being utilized by different hospitals. Because most of us are not aware. Since this Form O is passed by legislative body, you cannot change the framework of this Form O. It should be very clear with all. This Form O contains 2 pages. This is another form. This is Form 4. And it has been mentioned in the medical attendance rule that the pre-employment medical candidate statement and declaration should be filled up in this one. And this should accompany all initial medical examination for who have applied for appointment in the company. Now, in the 10th Safety Committee guidelines, it was found that the Form O, the space in the Form O was not sufficient to record all the clinical examination report and the investigations. So they decided to have 3 additional forms which were called the annexure to Form O to record all the investigations there. Now, whenever we do statutory medical examination, whether it is an IME or a PME, along with the Form O, you need to fill these 3 forms also. Coming to the next session, that is the periodical medical examination. This is again a health assessment which is conducted periodically, and it involves exposure to potential hazards which could not be entirely prevented by the control measures. It's a mandatory coverage. It applies to all persons employed in mining operations. And what is the periodicity? As per the DGMS guidelines or the mines rule, below 45 years, once in every 5 years. Above 45 years, once in every 3 years. It may be done earlier if medically advised. Medical examination of persons employed in mines conducted under 29B, Section B of Mines Rule 1955, the medical standards as per Form P. While PMEs are typically required every 5 years, the 10th Conference on Safety in Mines recommended shortening this interval to every 3 years for workers above the age of 45. In Western Coalfield Limited, the frequency of periodical medical examination for both on-roll and contractual employees is once in every 3 years. The circular number is already attached here. When we do the periodical medical examination, one of the medical examinations should be so arranged that it should fall in the year of superannuation, between 59 to 60 years. This is also as per the recommendation of the 8th National Safety Conference. Now, what are the statutory investigations that is done both for IME and PME? The hemoglobin, TCDC ESR, serum urea, creatinine, complete lipid profile, the routine urine, fasting and postprandial blood sugar, 12-lead ECG, lung function tests, audiometry, chest radiography. There are certain tests which are for specific health hazard. This is done specifically in PME. Employees who are engaged in food handling and preparation and handling of stemming material activities should undergo routine stool examination once in every 6 months. Sputum for AFB and radiograph once in a year to rule out tuberculosis. Employees engaged in driving and HMM operation jobs should undergo eye refraction tests at least once a year to ensure vision clarity. Employees exposed to ionizing radiation should undergo blood count at least once a year to detect early signs of radiation. Now, employees in the age group of 51 to 60 years should undergo yearly medical examination at respective OSCs to enhance physical and mental fitness and to improve safety awareness among those employees. This was advised in the 144th CMD's meet, that was in 2021. Now, the previous speaker, Dr. Pawan, has already explained this, the notifiable disease. A notifiable disease is any disease that is required by law to be reported to government authorities. And as per Mines Act 1952, these are the 8 diseases which have been notified in mining operations. They are silicosis, lung disease caused by inhaling silica dust, common in mining and quarrying jobs. It leads to inflammation and scarring of lung tissue. Pneumoconiosis of black lung disease caused by prolonged inhalation of coal dust, leading to lung damage and difficulty in breathing. Manganese poisoning, nervous type, a condition that affects the nervous system caused by exposure to manganese dust or fumes found in manganese mines. Asbestosis, a lung disease caused by inhaling asbestos fibers, leading to scarring of lung tissues and leading to increased risk of cancers. Cancer of lung, stomach, pleura and peritoneum. This is also called mesothelioma. Occupational exposure to harmful substances like asbestos can lead to the cancers affecting these organs. Noise-induced hearing loss, permanent hearing damage due to prolonged exposure to high level of noise, common in mining operations. Contact dermatitis and chemical exposure, skin inflammation resulting from direct contact with certain chemicals used in mining operations, radiation-induced conditions, health issues caused by exposure to radium or other radioactive substances which can affect multiple organs and bodily functions. Now, what are the other relevant provisions that is important in Mines Rule 1955? The Rule 29G says regarding retention and transfer of medical certificates. How long a statutory medical certificate be retained in the mines? This is very important. The mine managers should retain all statutory medical examination reports till a person is employed in the mine and also 10 years after his superannuation. This is as per Mines Rule 29G. What is 29H? Regarding the identity of the candidate. Whenever a person, be it IME or a PME, comes to the examiner for his medical examination, the examiner should ask for the unmounted 3 passport-size unmounted photographs. On verifying the person, the likeliness of that with the photograph, the examiner should endorse those photographs with the name and father's or husband's name of that person to be examined. 29I, medical examination of woman. No woman candidate without her consent should be examined by a male medical practitioner. This is very important. We had faced many issues. Please ensure that at least a female attendant is there in your room to all my medical practitioners, male medical practitioners here. Now 29J, appeal for re-examination. The appeal is made to the Appellate Medical Board. Under 29G, there is a provision that all cases of IME under Rule 29B or PME under Rule 29B, if the candidate is not satisfied with the fitness report, he can appeal within a span of 30 days. The application should be sent to the manager of the mine and should also contain a copy of the last medical report in Form O. 29K sends the constitution of the Appellate Medical Board. The Appellate Medical Board is constituted by, there is one medical officer, an allopathic medical officer, who is under the employment of the DGMS, who will be the convener of the board. There is another medical officer, allopathic medical officer, who is nominated by the Chief Inspector of Mines. And the committee will also have another medical officer from either the state health office or the central health office, not below the rank of the assistant civil surgeon. These are the board members of the Appellate Medical Board. And the provision of 29O, it is the cost for the medical examination. All costs for the medical examinations, whether it is IME or PME, should be borne by the employer concerned, the employer of the mine. Now, as per the recommendations of the 12th National Safety Conference held in 2020, details of every IME and PME conducted are to be uploaded onto an appropriately designed digital platform in a non-editable mode and also linked to the individual's Aadhaar number for easy retrievability. Western Coalfield Limited is presently having this facility. Though HMS is only in 6 of our hospitals in WCL, still we have got 2 sorts of software through HMS. The hospitals which are having HMS are uploading all their initial medical examination and PMEs through HMS. and the non-HMS hospital are uploading into a format which has been made by the systems department there. The record maintenance is also an integral part of our IME, PME. We need to maintain IME and PME registers. We need to preserve X-ray plates and the digital records. Maintain occupational disease register. Produce records before DGMS inspector. Documentation is a sort of legal protection. Now the conclusion part. IME and PME are not just routine medical formalities. They are a statutory shield, a preventive health system, a management safeguard, a worker protection mechanism. Thank you. Any questions or any queries, rather? Sure. Yeah. See, in medical attendance rule, we are having two groups. Group A, all persons who are involved in mining activities, like mining engineers, civil engineers, electrical, E&M, electronics, personnel, and even security, watch and ward candidates. These are all included in here. So if you get a paper where the designation is already established, a person is recruited as mining sardar, suppose, if that person comes to you for a medical examination. So we know that he is belonging to the Group A facility. There is no question of Group B. Okay? A person who has been already appointed as a security guard, he will be a Group A. A person who has been appointed as a management trainee, in bracket, it is electrical, or maybe personnel, or maybe mechanical, or maybe mining. He is always in Group B. But a medical officer is always in Group B. Now, I'm coming to it, sir. Now, there have been instances we have appointed people as general assistants, okay, which was earlier called General Mazdoor Category 1. People come to us as landowners or employment given through as on compassionate ground. They are appointed as general assistants. In general assistant, until and unless there is specific point that has been raised by personnel officer, that this person is to be given in surface or whatever it is, he is a differently able person. We are to take it as a case of to be employed in mining person, in that case.
What about the post of the medical officers?
Medical officer is always Group B. It's clear.
Many of the doctors are already unfit from the CIL.
Medical officers are Group B. They are not considered in Group A.
Due to the color blindness.
Always Group B. Anybody would like to differ from me?
Because they are not working actively in mines. For Group A, they are not actively involved in mines. Group A people belong to those persons who are actively working in mines.
No.
For active mining, Group A...
in any mining condition, you have to have the standards, you have to follow the Group B, Group A.
Yeah, Group A. For Group A, they are those who are fit for active mining. In Group A, they are drivers.
Yes,
like,
even drivers is in Group A.
drivers.
You are not supposed to make fit under Group B.
Yeah.
Anna, we will not make a person fit. Suppose a driver is coming to us, Anna, and that driver is a colorblind. Will you make him fit under Group B?
No.
Because the designation itself, by the designation itself and by the classification of medical attendance rule, he is a designated person under Group A. It is clear. What are the designations? Mining engineer, mining person, mining operations, civil engineer, E&M, mechanical, electronics, security, drivers, watch and ward candidates.
Ambulance drivers and sisters.
Watch and ward
also,
candidates. All others excepting this will come automatically under Group B. The only problem that we face, that's a real problem, whatever sir has said, that since general assistant, there is nothing written. It comes from the HR department, you are supposed to conduct. In that case, thinking it to be our prime operations is a mining operation. Okay? So we will take the standards as on Group A. As per Group A, he is unfit. Now suppose he is unfit due to color blind. Then we can explore whether this person can be made fit under Group B since he is a color blind person. Then the question comes under Group B. Okay. Yes.
He should be considered under the Part B as such. In that case, he will be made fit. But the same person, when he learns driving, etc., and he again applies for the driving post, naturally there is one examination known as pre-placement examination. Dr. Saab,
yes, yes, sir.
There is known as pre-placement examination, where the persons will be again re-examined, and if that person who was examined under the B, now when he is applying for the driver part, he will be made unfit because of the color blindness part. This is the last part.
Pre-placement examination is also done for security guards. Those persons who are deployed under security also, they also undergo pre-placement. They might be fit under Group A.
Many of the posts recruited by the recruitment department does not indicated the Group A or Group B.
Yes,
so
it's true. It's true.
Those so many confusions arising at the time of the IME examination.
Right,
like
right.
Recently one medical officer is already unfit from one subsidiaries. They appeal from the High Court and then other forum. After the final conclusion, it was decided the medical officer has already do the periodical medical examination in which the color examination is important, so that he cannot do his proper work. So after that he was unfit at the CL level also.
Yes, true. I think this needs to be sorted out while...
I would like to answer sir's question, the first part, regarding the doctor part, getting unfit in IME. There's a Supreme Court guidelines during the at the entrance level, when a person qualifies for MBBS and joining in medical college, there a medical examination is conducted.
Yes.
And their color blindness people are not allowed to study MBBS. This is a Supreme Court guidelines. I don't know how that person did MBBS and went on to join Coal India. As per Supreme Court guidelines, you should debarred from studying MBBS.
But we have doctors who are colorblind in our company also.
Yes, we have, and that's the reason we are facing now. They have been, after studying MBBS also, they have been debarred for joining the industry.
That's true.
Sir, there is one thing that why not it is incorporated in from the HR department, the person should be engaged in this department and examined under this Group A, Group B or Group C?
Yes, sir. That's a good suggestion. I mean, that should have been taken up by the policy cell.
It said it should be mandated that this person should be examined under Group A, Group B, Group C.
Unless a person, it is defined that this person will be deployed in this work. It's very difficult.
And should be examined under Group A, B, C, D. That would ease the burden to the doctors, defining under which group.
We can always give suggestions to the policy cell regarding incorporating these things.
Thank you.
Let's see how it goes.
Sir, I have few questions, sir.
Yeah.
Sir, as we know, there is a statute that the Form M should be issued 21 days ago.
20, yeah.
21.
Yes.
So, if the employee doesn't follow that guideline, then what should be done, sir? Should we send him back?
A second form is also given. After the span of period of 20 days is over,
No, sir.
Suppose he doesn't land up.
He comes within 3 days, sir. I mean, what the managers are doing, sir, they point out the guys which are not really important in production at those times.
Yeah.
And they send them for the
They are not maintaining the guidelines of 20 days.
Yes, sir. Yes,
Maybe he has just done night duty. He has come in the morning for his morning duty.
That's
he has been handed over the Form A.
Yes,
That
sir,
today
yes.
you are going for PME.
Sir.
So these things, you have to locally, you have to settle it down. Actually, the prime business is production. So we are all involved in production, so we have to manage everything. You cannot refuse a person who has come to you for PME.
So, sir,
We have found many a times, suppose a doctor who is sitting, you please sit down. Many a times, a doctor is sitting in a OHC room. He already has, say, about 10 PME, and suddenly he's sent a list of 20 contractual IMEs at around 11 a.m. in the morning, and he needs to complete those things. Now, how is it possible he's doing 10 PME? He may be asked to do morning rounds also, and he will have to also see patients in the OPD, or maybe he's on emergency duty also. And so many things. We had all this discussion in the DGMS meet also. The DGMS said, until unless these things are on paper, it is very difficult to. He said that you refuse examination, the maximum number of patients that you can examine is 20 in your span of, say, 6 hours. Now, already 40 people are lined up. How will you rule the other people's go? You say, just go home. And then the manager will say that it's not possible, it's not done. We had sent and you're refusing. Who will give the attendance? This is a big issue in our industry.
Sir, is it a real serious violation for 21 days? As you said that.
Yes, it is a violation. It is a violation.
And few questions more, sir.
Yes.
Sir, as you rightly pointed out about the recording of the data, of the PME data. So, sir, what's the official guideline regarding how many years after his retirement?
I said 10 years. 10 years after superannuation, you have to keep the records.
And sir, regarding digitalization of data, as we don't have any format which WCL has, so what we are doing is we are...
No, yesterday, just a minute, doctor. Yesterday I saw a notification that Coal India is taking up on a uniform pattern of digitalization of all statutory medical examinations of IME and PME. That is a very good step that has been taken up by Coal India. Yesterday only I think the notification has come. And let's see how it goes from maybe next year also the whole PME system will be changed. Now we are opting on to we are going forward to the OSH code, and where the medical examination has to be conducted once in every year. Once in a year, maybe, because we have to first see what are our infrastructure. That is more important, no? Because we do not have the adequate number of OH-trained personnel in our hospitals, or maybe ILO certified. It's okay to get an ILO certification. Are we really going through all the X-rays? Are we classifying what Dr. Pavan said? Each and every one of us should be classifying these X-rays, at least 4 to 5 X-rays daily, on a daily basis. We come, sit as a consultant and see a few patients and go back home. Nobody goes through those X-rays. How do we learn? Just by attaining your this ILO certification will not suffice. We need to go through X-rays, and we require regular fresher programs for ILO certification. I may have completed ILO certification 10 years back or maybe 20 years back. It's very difficult to remember until and unless we go through. I mean, Dr. Jain will agree with me. Dr. Rajkumar is also there. They'll be agree with him. Until and unless you go through X-rays every day, because we have to go through those minute shadows. We have to identify how to suspect. We are not suspecting cases. Occupational Disease Board, there should be one Occupational Disease Board in each and every subsidiary. This is as per the National Safety Guidelines, the 10th Safety and the 12th Safety Guidelines. And who are the members of that Occupational Disease Board? The physician, one of the senior most physician, one of the radiologists, and the occupational health physician. These are the 3 persons who are involved. And all suspected cases should be sent to the Occupational Disease Board for ratification. Once ratified, These cases should be sent back to the concerned area. From the area, the AMO or whoever is the in charge should send it back to the concerned unit. Then the unit manager, as per Section 25 of Mines Act 1952, Section 1, he is supposed to notify the DGMS authorities.
Sir, we are running short of time.
Oh, sorry. Just a line. Within 72 hours.
So one question only.
We are short of time.
I think you can take up the questions during the break.
Okay, I'll be there for the couple of days and I'll have a talk with every one of you. Thank you. Thank you.
Thank you very much, sir. Now, I would like to request Dr. Tikas, sir, to felicitate Neogi, sir, for this enlightening session.
Now we come to an end.
It is with great pride and deep appreciation that Southeastern Coalfield Limited recognizes HHL Life Care Limited for its exemplary service and unwavering commitment in successfully operating the Amrit pharmacies across SECL hospitals. So now we would like to welcome Vice President Mr. Rajesh R. Nair, sir, Retail Business Division, Zonal Head HLL, Amrit Pharmacy, New Delhi. I would like to request Dr. Shrutidev Mishra, sir, to felicitate Mr. Rajesh R. Nair, sir.
Dear delegates, we have a lunch at this hall only on backside, but don't forget we are having a very excellent session on ECG and critical care after lunch. And none other than Dr. Javed Parvez, he is a first electrophysiologist cardiologist at Chhattisgarh. He is coming with a good booklet, a very interactive session. And those who belongs to other specialty, please be seated, because this ECG workshop is not for MD medicine and physician or cardiologist. It is for all of us. It's a very basic ECG workshop. So request to all, please be attentive here for our next critical care and cardiac ECG session. Thank you. Thank you all.
We come to an end for the first session of the workshop today. We all break for lunch. And I request all the delegates to gather for the next session, which is to begin at 2 p.m. sharp. I request all the delegates to have their lunch and be in the podium, in the hall for the next session.
There's one more announcement. Delegates who are staying in Ananda Imperial should collect delegate kit from room 1001. And this facility will be available only till 2 p.m., not after 2 p.m.
All delegates who are staying in Ananda Imperial, kindly collect your delegate kits from room number 1001 in this particular venue itself.
I request all the delegates to kindly assemble in the hall and take their seats for the next session. We are going to start it very shortly. A workshop on ECG in ischemic heart disease. Our speaker is Dr. Javed Parvez, DM Cardiology, is Director Electrophysiology, ILS Hospital, Raipur. He is going to deliver his speech. His topic is on workshop on ECG in ischemic heart changes. I request all the delegates to kindly take their seats. We are short of time. We are going to start our next session.
Hello. Good afternoon, everyone. Those who are sitting backside, please come in front sides. Today is a workshop. Try to see the things. Dr. Javed is an excellent orator. He is master in ECG. He is a first electrophysiologist of Chhattisgarh. What we used to say, Dr. Narsimhan from KR and Dr. Amit Bora, Yaslu Khandwala. Now Dr. Javed is a first electrophysiologist available in our own Chhattisgarh at Raipur. So please come forward, sit. Those who are sitting outside, those who are taking lunch, please come forward. It's an interactive workshop. We have awards for questionnaire and it's a basic ECG workshop. So whosoever is from different fraternity, different branch, they can also join it. Please come.
Now I would like to request Dr. Javed Parvez sir to deliver his workshop on ECG in ischemic heart disease. Welcome sir. Sir, please take the stage.
Hello. Yeah. Am I audible now? Yes. So once again, I would like to request all the esteemed delegates to please take their seats so that we can go on with this session. And before I begin, I must thank the organizers, especially Dr. Arihant, Dr. Kalyan, and Dr. Parul for giving me this wonderful opportunity to be able to come in front of you and do this ECG workshop. So there are ECG booklets which are being distributed to you. And are we distributing the ECG booklets? Just start distributing the ECG booklets. So I've been given only 1 hour ultimatum. I have to stop by 3. Right. So if there are any DNB students in the hall, I would request them for an active participation and they can come forward so that we can have an interactive session and better viewing of these ECGs. So the workshop is designed in such a way that initial 5 to 10 minutes is theory, little bit of theoretical, information which is didactic. Then we go on to see some around 20 ECGs with actual case scenarios, how these ECGs were interpreted and how this interpretation helped us in managing these patients better. So I think, can I start? Yes. Okay. So the ECG is the most invaluable investigation. If you look at the cost of the ECG, it costs around 100 to 300 rupees. And the amount of information that the ECG provides is simply invaluable. If you know how to interpret the ECG, if you are well versed with looking at the ECGs, the amount of information the ECG gives, I think many a times it beats echocardiography, it beats a lot of other expensive investigations when compared with its cost effectiveness. So that's why this topic, and I'll be focusing basically mainly on ischemic heart disease. So these are the contents of our talk. So why ischemic heart disease? Because ischemic heart disease has become a pandemic in our country. And when I was a resident, or I would say when I was an intern, anybody with a chest pain with age less than 25, we had instructions from our seniors, send them off. Don't entertain them in the emergencies, entertain them in the OPDs. But that is no longer true. No age group is free of ischemic heart disease or acute coronary syndrome events. So the diagnosis of acute coronary syndrome is based on these three things. One is symptoms, other one is ECG changes and biomarkers. So symptoms, ECG changes and biomarkers. A classical symptom of an anginal pain, which is like a heaviness or a diffuse chest pain, either radiating to the back or radiating to the jaws, is very specific. But many a times in elderlies and females and in diabetic patients, you don't get these classical symptoms. So we need some more help. And then we have biomarkers. So that is your troponins, trop-I and trop-T. But in many situations like myocarditis or pericarditis, or in sometimes sepsis, even the troponins will be elevated. So what is left is ECG. So if you are well versed with the ECG, despite of these confounders, we can make a diagnosis of ACS with a lot of confidence. So this is the universal definition of myocardial infarction. You need three things. One is some evidence of myocardial injury, that is rise in troponins with at least one value above 99 percentile. You need some clinical evidence of acute myocardial ischemia. So not only just troponins, we need some clinical evidence, that is either new ECG changes, new pathological Q waves, or some imaging evidence or a thrombus. If you have these two, you have what is called as myocardial infarction. So what is the cutoff of diagnosing myocardial infarction? The cutoff is for men less than 40 years, it is 2.5 mm in precordial leads, ST elevation, and more than 40, it is 2 mm in precordial leads, and in other leads, it's 1 mm or above. In women, it is more than 1.5 mm in precordial leads. So we'll see these by examples, no need to remember these exact values. Now this is at the most basic level. If you look at the QRS, this is the P, QRS and the J point and T waves. So where the QRS meets the ST segment, that is called as J point. And if this J point can be elevated in these formats. So out of this, if you have this sort of J point elevation and convex sort of J point elevation, that is very significant for ischemia. We'll see certain more examples. This is again, ST segment elevation is defined or is classified into two types. One is concave and the other one is convex. So in concave, you draw a line from the peak of T wave to the J point, and if it is curving away from that line, it becomes concave. If it is curving towards the QRS complex, it becomes convex ST elevation. So convex ST elevation is almost always pathological. It signifies ST segment elevation MI, while concave ST segment elevation is most often benign. So this is at the most basic level. And again, the convex ST elevation can have certain types like straight up sloping, straight horizontal, straight down sloping. All these are pathologic and they are very significant, while this is lesser or it's benign. So this is how a 12-lead ECG looks on a paper, and you have the distribution of leads, lead 2, 3 and AVF. These are the leads which are inferior. So if you want to diagnose inferior myocardial infarction, you should look at these three leads, lead 2, 3 and AVF. If you want to look at the anterior or anterolateral sort of myocardial infarction, these are the lateral leads, lead 1, lead AVL, lead V5 and lead V6. What is remaining is V1 to V4, which are called as septal or anterior leads, looking at these myocardial infarction in these areas. So this is very, very basic. Then there are certain mechanism of ECG changes during ischemia. With the interest of time, I will not go there, but I'll just go through the clinical ECG pattern. So once you have a normal ECG, it looks like this. Then the most initial level, you have something which is called as peak or tall T waves. And then the ST begins to rise up. Then there is tombstoning. And once the ischemia settles, what you get is a Q wave and a T wave inversion. So based on what clinical setting, what is the time duration of the acute coronary syndrome, you can get ECG changes. Then localizing the myocardial infarction, anterior, it is usually because of LAD, V1 to V6, ST elevation, anteroseptal, V1 to V4, lateral, as I showed earlier, 1 AVL, V5 and V6, high lateral, 1 AVL, anterolateral, 1 AVL, V4, V6, inferior is 2, 3 AVF. Posterior myocardial infarction, you need posterior leads, which are V7 and V9, and RV infarction, sometimes you need right-sided leads, that is V3 to V4. Then, after diagnosing the classic ST segment elevation MI, what is the most important or very significant pattern that needs to be remembered is left main disease or significant multivessel disease. So if you have ST elevation which is there in AVR and V1, and it is more in AVR compared to V1, then you should be very, very careful that you are very likely dealing with either a left main lesion or a significant multivessel disease. So many of these patients do not come up with the typical anterior or anterolateral infarctions, but they come up with ST segment elevation in AVR and V1, and these patients are at much more risk compared to your anterior infarctions. Other than that, there are criteria. If you have ST segment depression in 8 or more surface leads, if you have ST segment elevation in AVR more than 1, and sometimes it becomes important to differentiate between a proximal LAD lesion and a left main lesion. So just compare the ST elevation in V1 and AVR. If AVR is taller or the ST is higher up in AVR, you are dealing with a left main lesion. If it is taller or higher in V1, you are dealing with a proximal LAD lesion. Okay, so localization, many times I get asked this by students that we want to learn localization of infarction onto the arteries. So localization of the infarct onto the arteries is important basically for the cardiologist. For at intensivist level or ECG enthusiast level, it doesn't make too much of a sense to dwell too much into localization, because many times it is confounded by multivessel disease or a previous pre-existing disease. So don't go dwell too much deeper into that. What you need to remember is, in anterior wall infarction, look into the inferior leads. If anterior wall infarction, the inferior leads are also showing ST segment elevation, probably you are dealing with a distal disease, and this has much favorable clinical profile or benigner prognosis. If you are dealing with anterior wall infarction and the inferior leads are showing ST segment depression, then this is much more significant, and probably you are dealing with a proximal LAD lesion. That much localization is enough for anterior wall MIs. Another important entity, RVMI, because it is commonly associated with inferior wall infarctions. So there are certain ECG criteria. Again, no point in remembering them. Just something very simple. If you have inferior leads ST segment elevation in 2, 3 AVF, look into V1 and V2. If you get something which is called as ST segment discordance, that is either ST is up in V1 and much more than up in V1 than V2, or ST is up in V1, V2 is showing depression, that is they are discordant. One is up and 2 is down. And or you have isoelectric ST segment in V1 with marked depression in V2. So in any patient with inferior wall infarction, you have diagnosed inferior wall infarction, look into V1 and V2. If you have something which is called as ST discordance, you have associated RV infarction along with that. And inferior wall MI with RV MI has much more poorer prognosis than compared to only inferior wall MI. Posterior wall infarction, again, this is an infarction which is commonly missed by many, even cardiologists I'm talking about. So how to diagnose posterior wall MI? Sometimes the patient can come up with only isolated posterior wall infarction. You get, you look into V1 to V3. If you get upright T waves with horizontal ST segment depression, the ECG looks like this in V1 to V2, think about posterior wall infarction. This is regarding conduction system, blood supply of conduction system. So only important thing is, if you have any bundle branch block, any fascicular block with any infarction, either it can be anterior infarction or inferior infarction, it carries worse prognosis compared to infarctions without a bundle branch block or a fascicular block. Then there are certain STEMI equivalents. So these are, the classical STEMI is quite easy to pick up. Then there are STEMI equivalents which carry the same significance as a STEMI, but only difference is you cannot thrombolize them. But the significance is almost the same. So there are certain, the examples are like De Winter's T wave, where you get this upsloping sort of ST segment depression in V1 to V3 along with tall T waves. We'll see clinical examples, and then we can have a much more idea about this. Regarding ST segment depression, so there are 3 types of ST segment depression. One is horizontal, downsloping, and upsloping. Out of these 3, you need to remember that this one is benign. If you have rapid upsloping ST segment depression, this is the first example, this is mostly benign, while these 2 are usually very significant. So that's why in majority of your TMTs, you'll see this upsloping sort of ST segment depression, and it is not given as a positive TMT. ST segment elevation, as I've already described, it's usually concave or convex. The convex is the one which you should be worried about. Concave is the one which is usually benign. Okay, so now we start the workshop per se. The theoretical part is over, and now I want certain active participation from all of you, if possible, right? So look at this ECG. So the format is there is an ECG, and there is a clinical question that follows, and the ECGs are numbered. So the booklets, which if you are unable to see the ECG clearly on the screen, you can open the booklets and see the ECG number 1. Right. So the question here is, this is the 45-year-old male patient, presents with chest discomfort. There is history of fever, sore throat 4-5 days prior. So the most basic question that I'm asking in this ECG is, the ECG shows which type of ST segment elevation? Convex, concave, or there is no ST segment elevation? It doesn't matter. Let's do an angiography and decide. So that is just for fun. So look at this ECG again, and I want some participation from anywhere. Yes, sir, please go ahead. Concave sort of ST segment elevation. So this is most likely to be benign or malignant, or you are dealing with ischemic or non-ischemic pathology. If you go back to the history, there is history of fever, chest pain, chest discomfort, and sore throat 4-5 days. So this is the ECG shows concave sort of ST segment elevation and not the convex one. You can see this ST segment elevation, and if you try to look into all the leads, you see that it is there in majority of the leads. Right, so lead 1, 2, 3, AVL, V1 to V6, all these leads are showing the same sort of ST segment elevation. We don't see any ST segment depression anywhere. So this is classical of pericarditis. Just a second. Yeah. So this is classical of pericarditis. What you get is concave sort of ST segment elevation, and it is seen in majority of the leads. And ST segment depression can be seen only in AVR and V1. And this is sometimes can be confused with benign early repolarization. If you want the exact difference, look into the T wave. The T wave is usually taller in benign early repolarization, and it is smaller in pericarditis. If you identify this as concave ST segment elevation, that alone is enough for me. So this is regarding ECG recognition of pericarditis. You get widespread concave ST segment elevation and sometimes PR segment depression, and you don't get majority of reciprocal ST depression except for this lead, which is AVR. So that's how you differentiate this with a acute ischemic event. Okay, nice. So let's go on to the next ECG, which is ECG number 2. If it is not clear, you can go through this in the booklet given. Have a good look at the ECG, and the question that follows is, this is again a 35-year-old patient with chest pain that subsided on its own, so that by the time ECG was taken, the patient was pain-free. The ECG was taken after the pain had subsided. Now what is the best approach here? This is a young patient, probably these are juvenile T waves, nothing else is needed. Let's do an echo or a TMT and then decide, wait and watch, do cardiac biomarkers, or none of the above. Okay, cardiac biomarkers you want to take and decide. What does the ECG show? Right, exactly. So deep T wave invergence is there in V1 to V3, V4, V5. And does this fit in any of the specific STEMI equivalents? Exactly, sir. A big round of applause for sir for giving that correct explanation. So, a purposefully given question there. So you see this, this is deep T wave invergence, which are symmetric and quite deep. So these are nothing but valence T waves. So valence T waves have types, type A and type B. So if you get something which is biphasic T wave inversion there in V2, V3, be very vigilant. If this patient comes with chest pain, no need to wait and watch. You can send biomarkers, but this is a STEMI equivalent. You need not waste too much time, and this patient has to be subjected to cath as early as possible. Why? Because majority of the times it responds poorly to conservative management, and it indicates a proximal LAD or an LAD lesion. So the large amount of myocardium is at stake if you diagnose type A or type B valence. So this is the normal progression of valence T wave. So the most initially you will get this terminal deflection there, biphasic T wave deflection. Then that terminal part deepens. That both of them are called as type A valence. Then it becomes deepened still, and then it can go into a symmetric T wave inversion pattern B. Sometimes it can progress to a frank elevation MI in the anterior wall also. Valence sign has a sensitivity of 24% and specificity of 96% to predict LAD culprit. So that is the reason to identify this STEMI equivalent is very important, especially because the patient comes to you without chest pain, and during the ECG the chest pain is not there. Okay, so I think we are moving on time. ECG 3, have a good look at the ECG number 3, and then the question is that follows is, this is a 62 elderly gentleman with chest discomfort since 5 hours. So the question here is, are we dealing with STEMI or this is non-STEMI? Let's do a 2D echo and decide. The fourth one is always, the cardiologists prefer this, refer and relax. Okay, so any takers for this? This is STEMI. Again, exactly. Which territory is involved, sir? Inferior wall is definite there. There is some ST elevation in 2, 3 AVF. Almost there are Q waves which are formed in 3 and AVF. What about V1 and V2? Who said posterior wall? Exactly, that's absolutely correct. So a big round of applause for sir, because that is the reason why I have put this ECG here. So this is not RVMI. You see, V1, V2 is not showing discordance. V1 is showing some ST depression. V2 is also showing ST depression. Most importantly, horizontal ST segment depression with an upright T wave. So this is not just inferior wall infarction. This is inferior plus posterior wall infarction. So these are the findings which are highlighted. Again, repeating posterior wall MI. Look into the V1, V2. And there should be a tall T wave with an upright R wave and horizontal ST segment depression in coving format. So if you have this, always be wary about posterior wall STEMI. That the ECG which I showed is a common presentation. Many times you can get isolated posterior wall MIs. So you get only this in the precordial leads and you don't get the inferior leads ST segment elevation. So this is a STEMI, right? We move on. ECG number 4. Now this looks familiar, I guess. We go on to the question for this ECG. This is an elderly gentleman with chest discomforts in 6 hours. 82. The precise age is 82. So everyone can diagnose that this is STEMI, right? Everyone knows that this is STEMI. Okay. So the question here is, what is the best management? It is too elderly, so we do not want to thrombolize this patient because thrombolysis is relatively contraindicated at that age group. The patient has already evolved MI. There are Q waves, so no need to thrombolize. Let us conserve. Give heparin and antiplatelets. Refer only after stabilization. I have put this purposefully because that is the most common approach. And it has been almost 15, 16 years, and I am yet to understand what that stabilization means. And then the fourth one is none of the above. Right. So, do we thrombolize this or not? The chest pain is of 6 hours duration. Yes? 6 hours. Okay. Right. Okay. Partly correct, partly not, maybe. Any other opinion on this? So see this, whenever the patient has ongoing chest pain, within first 24 hours, you can consider the patient for thrombolysis if the PCI center or angioplasty center is 120 minutes away. Anything less than that, primary PCI is superior to thrombolysis. So I purposefully posted this ECG to let us revise what are the contraindications for thrombolysis. Age is definitely not a contraindication for thrombolysis. And the patient is not at all stable. Because you see, there is the ST is still up and the patient has chest pain. So these two things are telling you, and the chest pain. So how do we calculate window period? We calculate window period from the time of maximum chest pain. If the patient had chest pains, let us say from past 12 hours, and the peak intensity was 6 hours ago, so the window period will become 6 hours. It's not 12 hours. That's how we judge that clinically. Otherwise, ECG-wise, the ST is still up, quite significantly up. So definitely a candidate for thrombolysis if there are no contraindications and if the PCI center is away. So this is a little old guideline, but still. So within first 12 hours, primary PCI, or even within first 24 hours, primary PCI is superior to thrombolysis. If it is not available, you can go for thrombolysis within that window period. After 12 hours, basically, thrombolysis is found to be very much inferior. Then after 48 hours, even primary PCI is not indicated if the patient is asymptomatic. These are the agents which are used for thrombolysis. Only one comment here, try to use 10 elective plays if possible, looking at the financial condition of the patient, because it is very, it is associated to infarct-related patency is highest for 10 elective plays if it is given within window period. So these are the contraindications for fibrinolytic therapy. If the patient had, if the patient had any intracranial hemorrhage anytime, if the patient has had stroke in the preceding 6 months, that is ischemic stroke, not an hemorrhagic stroke, or any neoplasm, any bleeding malformation, major trauma, active GI bleed within the past month, aortic dissection, non-compressible punctures in the past 24 hours, these are the only absolute contraindications. Age is not a contraindication. Blood pressure is again is not a contraindication. Refractory hypertension is a relative contraindication, otherwise it is not. So you can take a snap of this and keep it for your reference. We move on to ECG number 5. So, so look at this ECG. There are some changes, and then the question that follows is, this is a young patient with chest pains in 6 hours. What is the best management? Refer for angiography or angioplasty, urgent thrombolysis, serial ECGs to document ST segment elevation. Look at the ECG again. So he has come up with chest pain, ongoing chest pain. So what is the best approach? Want to thrombolize this? Angiography and angioplasty, that's right. Probably why? What is the ECG sign that is seen here? Yes, it looks like an already evolved infarct. And if you look closely, there is small R there. And there is a very small R there as well. And the T-wave inversion persists, and there is widespread T-wave inversions. So the best approach here would be, if the patient is clinically unstable, that is ongoing pain, or electrical or hemodynamic instability, urgent, catheterization followed by revascularization. We move on to ECG number 6. Now this pattern I'll keep on showing again and again, because this ECG pattern is what my take-home message for you all is. If you recognize this next time around, I'll be more than happy. I've done, my job well. If you recognize this 65-year-old male patient with chest discomfort, what is best for him? This is STEMI equivalent. Thrombolize him. Heparin, antiplatelets conserve, or refer him for urgent revascularization. Have a look at this ECG again. So what does the ECG findings, what are the ECG findings? Yes, absolutely right. Yes, absolutely right, sir. So you have hit the nail all on the spot, absolutely. So big round of applause for sir once again. So this is left main pattern. You have to just remember this, see this again and again, remember this, because many of these patients, they keep moving around, they can come up to you for a pre-surgical fitness, and you look at this ECG and you are like, my God, what I'm dealing with. So there is ST segment elevation in V1 and AVR. As I told you earlier, look into the ST segment elevation, which is more in AVR than V1. This becomes left main pattern. On top of it, you have these downsloping ST segment depressions in lot of leads. So for criteria of fitness, it requires 8 leads, but widespread is good enough. So this is left main equivalent pattern. Again, revising this for you. ST segment depression in 8 or more leads, ST segment in AVR more than V1. Okay, so can we thrombolyze these patients? No, we cannot thrombolyze these patients. This is a STEMI equivalent, but thrombolysis was tried in limited clinical trial data and it was found to be harmful. So the only thing that you can do is refer them after loading them with antiplatelets. Right, look at this now. Very grossly looking ST segment elevation in this ECG. So I don't think that all of you can easily identify that this is an infarction that is going on probably. Now the question that follows is interesting. What is this? Yeah. So this is a 65-year-old diabetic patient with sudden onset chest discomfort. He is in hypotension, 90 by 60 BP approach. PCI facility is not available nearby. So the best approach is heparin. Thrombolysis is contraindicated because if you use thrombolytic agents, the BP will go down further, or none of the above. And then there is a supplementary question, what is the culprit artery here? So look at this ECG again. So there is ST segment elevation in 1, AVL, V2 to V6, right? And there is very significant ST segment depression also in inferior leads. So you are dealing with a proximal LAD lesion. So what about thrombolysis in hypotensive patients? Can we go ahead and do thrombolysis? Yes, absolutely. So 90 by 50 BP or 80 by 60 BP is not a contraindication. Only thing is, I don't think anyone is using streptokinase these days. Streptokinase was associated with first dose hypotension. So it was a relative contraindication to use a streptokinase with this sort of clinical presentation. Otherwise, even in hypotension, put the patient on inotrope, give thrombolysis. Thrombolysis works if the PCI facility is not nearby. Hypotension or hypertension is not a contraindication. Hypertension is a relative contraindication, but not absolute. Again, I've revised the contraindications to fibrinolytic therapy. You can take a snap and keep it for your reference, because this is a common scenario in our peripheries. These are the relative contraindications for fibrinolytic therapy. We move on to our next ECG, that is ECG number 8. Have a look at this ECG. Now this is where things get interesting. Yeah. So this is an elderly patient with chest pain, develops syncope in emergency room. So basically faints in the emergency room. So the questions are, this is STEMI, non-STEMI, and what was the cause of fainting here? STEMI with complete heart block. Yes, I would say so. Yes, yeah, complete heart block is definitely there. What was the cause of syncope? What is the infarction here? So ST segment elevation in V2 to V6 and reciprocal depression is not there. So, but AVR is showing significant ST elevation, right? And definitely there is a rhythm disturbance that is going on, that is complete heart block. The prognosis is poor because AVR is showing ST elevation, there is complete heart block or a 2:1 block. Then you have this QRBBB, but the cause of syncope is, in all these patients with acute MI, Never ever a complete heart block causes fainting. It is always VF. Remember that. It is always ventricular fibrillation that causes syncope. So any patient who has got an MI or underwent recently angioplasty collapses anywhere, think about only one thing, that is ventricular fibrillation. Okay, now we move on to ECG number 9. So there are two ECGs here. One is 9A and 9B. Have a look at these two ECGs, both of them. Then we go on to the question that is associated with this. So these two ECGs were taken 4 hours apart in an elderly patient who presents with anginal pain. So now the question is, which was the ECG which was taken during pain? Again, this is to emphasize a certain important physiological point. 9A and 9B, which among these two ECGs you think would be during an ongoing anginal pain? A or B? A, very right. Why not B? See, the 9B shows T wave invergence in V1 to V3 or V4, V5, right? ST segment depression is there, which is horizontal, nothing suggestive of acute ischemia. So many of these patients of chronic left ventricular hypertrophy or old ischemic heart disease have this sort of T wave invergence. So whenever an inverted T wave become upright associated with some ST segment elevation, it is called as pseudo normalization of T wave. A T wave which was inverted becomes upright, and it becomes upright only during angina. So that is another important marker of acute ischemia, is pseudo-normalization of a T wave. The same thing which is highlighted here. Okay, now this is a 48-year-old patient who presents to the emergency room with this rhythm. So basically he has, what is this rhythm? Exactly, this is VF, this is not VT. And this is not torsades also, this is VF. And we defibrillate him, we revert him to sinus, and then we look at this ECG, we get this sort of ECG. So the question here is, the post-defibrillation, there are widespread XC segment elevation. Are these changes because of DC shock, and these are likely to revert to normal? So, we should conserve, the management line should be conserved or refer him immediately. Again, highlighting the same point, that if the patient has had VF, if the primary PCI facility is away and you get this sort of ECG segment, ST segment elevation, thrombolysis, otherwise primary PCI. And post defibrillation or a DC shock, you can get transient ST segment elevations, but these are limited to V1 and V2, never extensive. Here you are seeing extensive ST segment elevation in 1, AVL, V1 to V4 with ST segment reciprocal depressions. So this is clearly ischemia. Yeah. So ECG number 11. Okay. Now we move on from the acute ischemic presentation to chronic ischemic presentations. So look at this ECG. And this patient has presented with stroke, CVA, right hemiparesis, diabetic, and history of old enterovolemi 2 years back. Now the question which I am asking is whether this stroke has got anything to do with his coronary artery disease or not. And the answer lies in the ECG. Who said yes? And why? Why? Okay, agreed. Right? Yes, agreed. Absolutely right. The most important point which sir mentioned was LV aneurysm. And there is a clue to LV aneurysm in this ECG. I don't know, where is Dr. Arihant? He promised me that he'll give some prizes to the correct answers. And this is a gem of an answer. It cannot go without a prize. I don't know where is he. Okay, so maybe I'll get to the prize later. Yeah. So most of the things were correctly pointed out by sir, that there are widespread Q waves. 2, 3 AVF are showing Q waves. But the most important thing is V5, V6 is showing ST segment elevation. So persistent ST segment elevation. Go back to the history. There was MI which was 2 years back. So why should the ST be still up after 2 years? So that should give you, the clue that this patient is having a LV apical aneurysm. That's why in my opening statement I said ECG gives you almost invaluable information. Only thing is one should be aware of, the mind only sees those things which, the eyes sees only those things which the mind knows. So you have made a diagnosis of cardioembolic stroke, LV dysfunction, LV aneurysm, just by looking at this ECG with little bit of clinical history, only 300 rupees spent, and you have this much information. I don't think any other investigation in medical science can provide you that much information with respect to the cost involved. Right, so that was brilliantly picked up. So this is the persistent ST segment elevation. Now we move on. We have 6 more ECGs or 8 more ECGs to go. So look at this ECG again. There is some bradycardia with some ST segment elevation. Now the question that follows is, this is a 55-year-old patient, history of chest pain. He receives nitrates for the chest pain in emergency room. And the question is whether that was appropriate or not. And if this sort of arrhythmia is common in this type of acute coronary syndrome. So look at this, and now you have to tell me. So what infarction are we dealing with? Who said RV? Somebody said RV. That's right. Who said RV? Yes, absolutely correct. Why do you say so? RVMI? Yes, exactly. So now you have picked up the clinical marker, that is ST discordance in V1, V2. So whenever you have this inferior MI, 2, 3 AVF, always look into V1, V2. You don't need right-sided leads. Even looking at the basic ECG, you can come to a conclusion that the patient has RVMI or not. So this is an old school thought, but majority of the RVMI patients, they usually present with hypertension. So giving nitrates is not a very good choice in these patients because the left ventricle output is dependent on preload. And if you give nitrate, the preload drops and the patient sometimes can land up in refractory hypertension. So that was this. And if this sort of arrhythmia is very common, bradycardia probably looks like atrial fibrillation. Yes, it's not uncommon in inferior MI. So we move on. Again, I've repeated that, but all you need to remember is ST discordance in V1 and V2. Okay, ECG number 13. Now, again, very interesting ECG here. Very subtle, important findings here. So this is a diabetic patient, elderly, presents with sudden onset breathlessness. The ECG is consistent with hypokalemia or acute ischemia, and the patient is at risk of sudden cardiac death, yes or no. How many for hypokalemia can raise your hands? And how many for acute ischemia? None for none? Yes, I saw one hand raised there. Hypokalemia or acute ischemia? Acute ischemia. Is the patient at risk of sudden death? Yes? And why? Absolutely right. There is significant QT prolongation. So the QT interval is one of those things which is often missed by, experienced people also. So always before turning over an ECG, remind yourself that I need to look into the QT. And how do we do that? It's not very difficult. Okay, so measure the QT interval from the onset of QRS to the end of T wave and compare it with the previous RR interval. So this is the QT interval, compare it with the previous RR interval. You don't need to, actually in millimeters count the QT interval. If the QT is more than half of the RR, it is prolonged. So that is the most basic level. Otherwise, the machines these days, they do an automatic calculation and give, but that calculation is often wrong. because the machine cannot truly identify where the T wave ends. So this always works. Okay, so there is widespread QT interval is prolonged, the T waves are inverted, and then that is the one which I think got missed. So there is an ectopic which is sitting right there onto the rhythm, and this is a narrow complex ectopic. This is a ventricular ectopic because all the other QRS complexes are different from these ones. So these ectopics are very dangerous, especially if the QT interval is prolonged. So always remember, ectopics, we tend to neglect the ectopics during the ECG, but if the QT interval is prolonged, always think about that this could be something very dangerous, and that, that can precipitate torsades. When the QT is prolonged and ectopic is coming just at the end of T wave, if it falls on the top of T wave, it can precipitate what is called as torsades repoints, a polymorphic VT, which is very dangerous. And it frequently progresses to ventricular fibrillation in almost no time. So these are the causes of QT prolongation in an adult. This is how I was taught in my fellowship days. So this is the same thing which I am transmitting to you. The first three causes are acute ischemia, and acute ischemia. Always try to rule out acute ischemia, then only think about the other causes, that is hypokalemia, hypomagnesemia, hypocalcemia, and drugs. So so the next question is, why not hypokalemia in the previous ECG? Why acute ischemia? The answer is this. U wave remains upright, PR interval prolongs in hypokalemia. In acute ischemia, the U wave also inverts. So in our ECG, there was U wave inversion and not the upright U wave which is associated with hypokalemia. Okay, ECG number 14. Have a look at this ECG. Looks innocuous, right? This is post-op day 3, post-cholecystectomy, develops chest discomfort. What is the better approach? These STT changes are because of tachycardia. There is rapid upsloping ST segment depression. Wait for the tachycardia to settle and repeat the ECG. No, this is definite ischemia, acute ischemia, activate cath lab. Who said that? It's in AVNRT. Okay, other than that, what about the STT changes? I saw a hand went up there. Absolutely brilliant. Yes, Dr. Arihant, you had promised some gifts, and all these people have been answering these amazing ECGs, and I don't know where are those gifts. Okay, so big round of applause for sir. So absolutely terrific pickup. Look at this V1 and AVR. There is ST segment elevation in AVR which is more than V1, and if you count leads, there is ST segment depression in 1, 2, 3, AVF, V2 to V6. So this is classical left main equivalent pattern. It cannot be, sir, because rate reduced ischemia is upsloping ST segment depression, rapid upsloping ST segment depression, never ST segment elevation. So these are actual case scenarios. This patient had a lap cholecystectomy was done. Everyone, including our anesthetist, was happy. Now this is because of pain. Let us give some analgesia. This will settle down until the ECG showed this. So this is left main equivalent. So it can present in variety of forms. That's why my take-home message for you today is just this slide. Identify left main pattern with confidence next time when you see it. Rhythm, sir, rhythm is probably sinus. You can see there are small P waves which is here. Small P waves, and every P wave is followed by a QRS. This is not an AVNRT. Okay, again, those things. ECG 15A and 15B. Now look at these ECGs again. Again, there is some point that I want to make. So that's why these two ECGs are given. This looks, there are certain ECG changes, STT changes in 15A, and 15B, there is ST segment elevation. Now the question is, which one of those ECG patterns are much more dangerous in terms of prognosis? Is it 15A or 15B? So any noise or anyone with a little bit of information will say that B is more dangerous because it is showing gross, anterior wall MI. But look at 15A. What does it show? Yes, again this is left main pattern. So this is more dangerous because it is showing ST segment elevation in AVR more than V1. So the first one is V1, it's not labeled there. That's V1, V2, V3, V4, V5, V6. So there is ST segment depression in more than 8 leads. AVR is showing ST elevation more than V1. So this patient has left main occlusion. So we are, so in terms of prognosis, what are we talking about? We are talking about a lesion that is either here or there. So if you have a left main lesion, the LCX is also compromised. If you have a proximal LED lesion, the LCX is spared. So out of the two, obviously it is the left main lesion which is much more dangerous. It is not that the proximal LED lesion is not dangerous. It's also dangerous, but left main is left main. Right. So I showed so many ECGs, variety of presentation of left main because I want that to be my take-home message from here. Next time you see a left main pattern, do not miss it. Again, revision of those points. Okay, these are the changes highlighted for you. So this is, the other one showed, proximal LED lesion. The previous one was left main lesion. So now 4 more ECGs, then we can stop. So this is, another very important clinical point which I want to score here. That's why this ECG and the question that comes with it. So this is a 30-year-old male which presents with chest discomfort at 5 a.m. in the emergency room. You do a cardiac biomarker which is negative, and probably the patient was discharged with an advice for TMT for the next day. What do you think? Is it the right approach or wrong approach? And you have to tell me why. Absolutely, it is a wrong approach, yes. So another prize-worthy answer. So big round of applause for sir. But the real reason that this is wrong approach is, it's very simple. You don't need to look at the ECG. If somebody comes with chest pain at 5 a.m. in the morning, you cannot simply discharge the patient. You simply cannot discharge the patient. Whether that pain is psychological, functional, muscular, whatever it may be. He has come at 5 a.m. in the night, keep him in the hospital, observe him, do not discharge. And as sir rightly pointed, there are, crucial clues on the ECG. So another most important thing to look at is when you get such sort of ECGs which are not clearly indicative of ischemia is to have a look at previous ECGs. The previous ECGs, the information that we get from the previous ECGs is absolutely invaluable again. So look at this patient's previous ECG. So the T wave in AVL was upright, while during presentation, this T wave was inverted. And as sir rightly pointed out, there is some horizontal, the ST segment is hugging the baseline before going up. So there is acute ischemia that is going on. And if you do cardiac biomarkers very early in the stage of the disease, they can be negative. So the take home message is, somebody comes with chest pain at night, 5 a.m., do not discharge the patient. So this patient developed frank inferior wall MI just 2 hours after his presentation. So while being shifted to cath lab, there was frank ST segment elevation. New onset T wave inversion in the context of angina are very significant and they are not to be neglected. Their specificity varies from 75 to 85%. Couple of more ECGs. Okay, another one of those benign sort of presentations. I think we covered this issue, right? Why it has come back again? Okay, this is to show you the ST hugging the baseline. Sometimes it becomes flat like this, it hugs the baseline, it doesn't go up immediately after the J point, and in the context of angina, that ST hugging is also significant, not to be missed. Okay, just a couple of more ECGs, ECG number 18. So the ECG shows whether the right bundle branch block interferes with the diagnosis of STEMI, or the ECG suggests a favorable prognosis in acute coronary syndrome, yes or no. So as I earlier mentioned, any sort of bundle branch block, any sort of fascicular block in the context of MI confers a poorer prognosis than without the block. And with regards to right bundle branch block, it does not interfere with the diagnosis of MI. Basically, you can see here that there is ST segment elevation in V1, V3, V4, V5, and a very typical right bundle branch block, which is called as QRBB. So there is an infarct which is already developing into the septum. That is the reason why the right bundle is getting damaged there. So QRBB favors poorer prognosis. QRBB in an anterior wall MI tells you that this is a proximal LED lesion. Just second last ECG. So yeah, this is again showing some very innocuous presentation of acute ischemia. So the patient with chest pain presents with this ECG. The chest pain is likely cardiac, non-cardiac. Do a treadmill test and decide. So we'll spend some time, you allow some time for the attendees to have a look at this one. Yes, voice your opinions. What do you think about this ECG? He has chest pain, so only two choices. This is cardiac pain, non-cardiac pain, or we don't know. Put the patient on a treadmill and decide. Likely cardiac? Definitely cardiac. Definitely cardiac. There is left ventricular hypertrophy on the ECG, yes. Right? So, but left ventricular hypertrophy does not signify acute ischemia. Yes? Biphasic T wave, it does not look convincingly biphasic. Is it biphasic to everyone? I don't think so. You see, V1 T wave is usually inverted, so it's normal there. V2, I really cannot be sure about this terminal T deflection, whether it is biphasic or not. There is something much more specific other than that. So this is a sign which is seldom looked upon as a feature of acute ischemia. So what are these waves? What comes after the T wave? What comes after the T wave? U wave. So the normal U wave is upright or inverted? Upright. So normally the U wave follows the T wave. If the T wave is upright, the U wave will also be upright. Here what you see is the T is upright, U is inverted. That's a sign of acute ischemia. So this is definite cardiac chest pain. No need to put the patient on TMT. He might develop even severe ischemia if you do that. So this is about the U waves. In patients presenting with chest pain, inverted U waves are very specific signs of myocardial ischemia. And again, they predict left LAD or LMCA lesions. So they are very, very significant. So last ECG, I'm on time. We started around 2:10. So this is just around 3 o'clock, 2-3 minutes past 3. So last ECG. So this patient has chest pain, 4-hour duration. Do you want to activate cath lab? Or do you want to wait for troponins? Because left bundle branch block interferes with the diagnosis of MI or STEMI.
We will activate the cath lab.
Right.
Because there is, we normally predict that with LVV there should be reciprocal T inversion.
Right.
But we see that in 1 in AVL there is ST elevation. So by modified Garbosa criteria, this is interval MI.
Absolutely, absolutely correct, sir. So I'll simplify this for you. So whenever you have a bundle branch block, it's a repolarization abnormality. So in right bundle branch block, you have the M pattern in V1 and the W pattern in V6. So I'm simplifying things so that the youngsters can take note and it becomes easy to understand this. In left bundle branch block, it is a W pattern in V1 and M pattern in V6. And what happens to the T wave? It is usually the opposite of the QRS. So in a normal left bundle branch block, you get this sort of M pattern in 1 AVL, V5, V6. and which is, bifid sort of a QRS, and the ST is always opposite to the direction of QRS. So whenever you have ST segment which is concordant to the bundle branch block or the QRS in presence of left bundle branch block, that is very, very significant, and it defines acute ischemia. And the other thing is to look at discordant ST segment depression. So whenever like in V1 to V3, you expect this sort of a QRS, and the ST segment is in the opposite direction of the QRS. But if you get ST segment depression here, that becomes a concordant sort of ST segment depression, and it becomes very significant for ischemia. Otherwise, the QRS is in the expected direction, but there is, like in V1 to V3, you get this sort of ST segment elevation, which is more than beyond expected. Then that becomes very significant, and that is what this Barbosa's criteria. Very difficult to remember exactly how much the score, this and that, but always remember that repolarization or abnormality is always, the T wave is in opposite direction of the QRS. If it is in the same direction or the ST is in the same direction, very likely you are dealing with an acute ischemia. So with that, I think, yeah. So these are all the signs put together on a given ECG. If any of these are present, all of them can, suggest acute ischemia. So if you have Q waves, they indicate evolved infarcts. If you have a convex sort of ST segment elevation, it tells you that this is an acute ST elevation MI. ST segment depression can be either horizontal, downsloping, or upsloping. So if it is downsloping or horizontal, it is usually, it indicates ischemia. The upsloping one is the one which is benign. If the ST hugs the baseline with upright T wave, it also indicates ischemia. QRBB tells you that this is a proximal LED lesion. New onset left bundle branch block or any fascicular block along with the MI worsens the prognosis. If you have T wave invergence, especially those of the valence type, indicate proximal LED lesion. Pseudo-normalization of T wave, you can pick it up only if you look at the previous ECGs, hyperacute T waves, QT prolongation, and last and not the least, U wave invergence. Do not forget the U waves and the QT. So next time you turn over the ECG, always remember or always remind yourself that have you seen the QT or not. So with that, I conclude, and I thank once again the organizers and especially Dr. Arihant for giving me this wonderful opportunity. If there are any questions, I'll be happy to take them. Thank you. Okay, fine.
Thank you, sir, for the enlightening session. Now I request Dr. D.B. Sonkusre, sir, ex-CMS ACCL, to kindly felicitate Dr. Javed Parvez, sir, with a shawl and a memento. Sir, please. Thank you, sir. Now, for the next session, I would like to request Dr. V. Ravishankar, Consultant Critical Care, Yashoda Hospitals, High Tech City, Hyderabad, to kindly come over the stage to deliver his talk on ECMO and transplant critical care. Sir, please.
Due to some printing mistake, this talk has not been in your brochure. So this is a scheduled talk. I'm sorry for that. I request Dr. Ravishankar.
So, good afternoon, everyone. I am Dr. Ravi Shankar. I come from Yashoda Hospital, High-Tech City. So, today I am going to talk about the ECMO basics. So, before I start on the topic, I want to ask you a simple basic question. How many of you have seen a patient on ECMO? Okay. So, how many of you have heard about a patient on an ECMO? Okay. So, I'll try to, cover the basic part, because, what I'm trying to talk here is, when should you think about a patient that this patient is going to need an extracorporeal membrane oxygen support. So, why I'm going to talk about this particular topic is because I hail from a center which is a platinum certified center, which is the largest quaternary care center in the Southeast Asia, and it is a platinum certified, which is one of the 40 centers in the world which practices ECMO. So the other question is, do you think this ECMO can be initiated in Bilaspur? How many of you think yes, and how many of you think no? No answer. No. Okay. Yeah, so I have asked the ChatGPT to put me an image. So can this be done? This is what the ChatGPT has given me. So I will try to cover when should you think about ECMO and who needs an ECMO and where it can be done. This is the first question which we are going to ask ourselves. Then how to initiate and what is the survival rate. I am going to talk about the data what we have and how much does it cost, and is it all good post ECMO, all these things I will be just trying to brush up. So ECMO is nothing but a basic cardiopulmonary machine which has been there for many years in our cardiac OTs. It is a modified, extended version of the same cardiopulmonary machine which can be used for a prolonged time. If you look at a CPP machine, it is quite big. When you compress it and make it as simple as possible, that becomes an ECMO machine. So how this ECMO became very famous in India? Because it was there in the West for quite some time. But the first episode was probably in 2009 when we had swine flu, and where majority of the patients developed ARDS and they were not able to ventilate those patients, and that is when the ECMO came into clinical practice. But the biggest wave which hit across the world was the COVID wave, where this bloomed like anything, where many of the patients went on to require ECMO eventually, and that is when people started talking and looking about whether ECMO is a life support or not. So if you look at our hospital itself has close to 10 machines, and we do almost close to 1 to 2 ECMO per week, and Hyderabad city itself has more than 20 ECMO machines. So this is how we rapidly progressed. And this is what I was talking about. This is a ECMO certified center. This we have received the award in the Washington DC last year. And there are, as I said, this is only one of the centers which is there in India which is platinum certified. So I'll show you an image. This is an image of a patient who is a 21-year-old male who is a case of scleroderma related ILD, and he was on long-term oxygen therapy, who was listed for lung transplantation basically. But unfortunately presents to us with an acute exacerbation of the ILD and goes on to require oxygen support, HFNC, then initiated on NIV and ventilation. Then we have initiated in a machine where you are able to see this patient who is not having any tube, any oxygen, still he is able to walk. Can you identify what is the machine there? That is an ECMO machine. So if you look at your patients on ILD, most of the patients would not be looking like this. They'll be gasping for breath, they'll be on very high oxygen, and they would not be mobile like this. They will be bound to the bed. And this is what it can do. And we can do this. This is a patient who has been initiated on an ECMO, and despite ECMO support, if the patient is not maintaining adequate oxygenation, we can still prone the patient on the bed itself. So all these are the complexities which we can do. I'm not going into these complexities. Before I start, can you identify this person? I think, he is known across India. And I think during the COVID wave, there are two important personalities who made this ECMO machine famous. He is none other than SP Balasubramaniam He is a famous singer in India, and he was on ECMO during the COVID wave. I hope everyone can recognize her. Jayalalitha, yes. So she is ex-Chief Minister of Tamil Nadu, who also has undergone ECMO during her sickness state. So I'll try to broadly simplify this topic because I'm not going to dwell into the core of the ECMO. So basically there are two types of ECMO. One is veno-venous ECMO, the other is veno-arterial ECMO. Veno-venous ECMO is nothing but you take the venous blood and push back into the venous system. That's why it becomes a veno-venous ECMO. Basically, the blood goes through an oxygenator, which is similar to your lung. So any patient having a hypoxia, the blood flows through that oxygenator and you will be able to deliver the oxygen to the patient. So that becomes a veno-venous ECMO. But when you want to support the heart, this system is not sufficient. So you use a veno-arterial ECMO where you drain the blood from the venous system and you pump the blood into the left side of the circulation, that is into the aorta. That becomes a veno-arterial ECMO, basically simulating how your heart functions. It drains the blood and pumps the blood into the arterial circulation. That is exactly with the machine what we are trying to do through a veno-arterial ECMO. So there are other different configurations, that is veno-arterial, venous. All these are hybrid ECMOs. I'm not going to go there. And these are the cannulas typically which we use, which we insert into either the jugular vein or the femoral axillary subclavian veins. And these are the cannulas, how they appear when we insert into the patient's body. This is a veno-arterial configuration, and even a patient on a veno-arterial configuration, if you see, patient has been mobilized to a chair with a veno-arterial ECMO on situ. The machine consists of different parts. The main part is the console, which controls how much flow should happen, and all the settings can be set on the console. And this is a portable machine. This is a Rotaflow 2, which is as small as your laptop, which can be carried on hand, and patients can be transported across the world, anywhere with an ECMO machine. And this is the main core component of the ECMO machine, that is the oxygenator, where the blood flows through this oxygenator and the gas exchange happens in this oxygenator, where the oxygen gets added to the blood and the carbon dioxide is being removed from the blood, like what your lung in your body does. And to circulate the blood across this machine, you need a pump. That is a pump which pumps the blood constantly through the circuit. The blender which controls your oxygen, how much oxygen you want to give the patient and how much carbon dioxide you want to remove from the patient, are being controlled by these blenders. So what we do initially is, when you want to initiate, you fill the circuit with fluid or blood, then you put a cannula, connect the cannulas to the circuit and start the ECMO machine. That is how you do. So this is how the cannula appears in reality. That is a large cannula which is going through the jugular vein into the right side of the heart, and that is a echocardiographic image of the same when you put a cannula there. And these are the large cannulas which you can see. The blue ones are usually the venous cannulas which drain the blood. The red ones are the return cannulas where you return the blood into the patient's body. So there are different dual site cannulations available. So again comes a question. Do you think ECMO is not available everywhere? So only you can initiate ECMO in only healthcare settings, or ECMO can be done in a large centers like where we routinely do, or you can transport ECMO patients from one hospital to other, or ECMO patients can fly in air ambulance. So which one do you think? In fact, all of this can be done, not just one, because this is a patient where we have initiated ECMO at a very peripheral center, where we got a call that the patient had collapsed and the patient was in shock. So we fly there, we initiate ECMO, then do an air transfer or a road transfer depending on the circumstances. So these are the principal indications for an ECMO. Any patient who is having hypoxia will essentially requires veno-venous ECMO. Any patient who is in shock because of a cardiac cause, whatever the cause may be, will be requiring a veno-arterial ECMO. So these are the indications of an ECMO in a case of an ARDS patient. Is there any contraindication? Yes. Patients who is not expected to survive long, a patient with an end-stage malignancy, or a patient who is a contraindication for an anticoagulation, because when the blood comes out of the body, it needs an anticoagulation. So any patient who cannot tolerate anticoagulation would be a bad candidate for a ECMO. So I'll try to show you some cases what we have done. This is a 50-year-old female who is a leptospira positive. I don't know whether how many of you see leptospira in this part of the country, but in the southwest belt, leptospira is very common, and leptospira presents with a multi-organ dysfunction syndrome. So this patient comes with a leptospira multi-organ dysfunction, and this is her CT scan of the chest, where she presents with a severe hypoxemia, and when we look at the CT chest, this is how it appears. And this patient was intubated, prone ventilated, but despite which oxygen was not improving, and this is the X-ray and the oxygenation status of that patient. So even after 6 hours of proning, because there was no response, then we had to initiate ECMO on her, and this is post initiation of the ECMO, and this is how after the recovery she looks like. And this is one of the rarest of the cases, because there are only 3 reported cases across the world where in the US, where they have done ECMO for a patient with a leptospira ARDS, the patient didn't survive. There was only one survival patient before this from Thailand, and this is the second patient who has survived. Then I'll talk about another subset category of patient, a young female, B.Tech female who works in a corporate company, comes with the alleged ingestion of multiple tablets of beta blockers and calcium channel blockers. She presents with a basically beta blocker and calcium channel blocker overdose with a severe shock. Basically, this is a typical vasoplegic shock because of the drug induced. So what we generally do, we start them on vasopressors, resuscitate them, then try insulin, glucagon, everything possible till the drug effect, tries to fade away. But in spite of which the patient started deteriorating and the shock worsened, she was on triple vasopressors, lactates creeping up, and there was already metabolic acidosis setting in. So this patient, again we have initiated, arterial ECMO, because this patient needs a circulatory support, not just respiratory support. And this is post-recovery of that patient. Then there is another third case, which is young female. Again, she went for an ovary stimulation process in a fertility center. And because we all know the drug-induced hyperstimulation syndrome does happens, and it typically behaves like a capillary leak with severe sepsis, mimics sepsis. Then she collapsed in the OT, the BP was not recordable, and with an ongoing CPR, this patient was shifted to our center. And by the time she reached the emergency post-resuscitation, she was on 40 ml of noradrenaline, 20 ml of adrenaline, vasopressor going, very feeble pulse, not able to resuscitate her. Then we did emergency cannulation in the emergency itself, and this is how we are doing in the emergency. Post-resuscitation, we tried to initiate her on ECMO because she needs that circulatory support. Because if you leave her at this stage, she goes into an irreversible organ injury. From there, salvaging might be very difficult. And this is the shortest ECMO which we have ever seen, because within 24 hours, because once the effect is over, the heart returns back to the normal. So within 24 hours, we were able to wean off the ECMO, and 48 hours, the ECMO was removed, and within 72 hours, the patient was discharged. So what is important, before I go to what is important, the last case. So again, the same question, can we do ECMO in Bilaspur? Yes, because we have done in remote center. So this is a case which I will try to bring from Bhimavaram, which is one of the remote centers in state of Andhra Pradesh, where there was a young chap who had 41-year-old male, fever with chills, followed by shortness of breath, then he had a shock, then he was admitted in a local hospital with a cardiogenic shock where he was initiated on some supports, and then he started to develop multi-organ dysfunction syndrome. Then we got a call whether can we initiate VA ECMO in this patient. And this is the distance from our center to the peripheral center in the remote area of Andhra Pradesh. So by road, it takes around 8 hours, 17 minutes. So how do we do it? So what we did, we took a flight to the nearest center through an air ambulance, and from there we took an air ambulance, and this is a hospital where we have initiated a VA ECMO, and this is a transfer process where air ambulances are readily available now where we initiate, and this is a bedside echo assessment of the patient in that hospital, and we have done a VECMO femorofemoral configuration and initiated him, then airlifted him back to Hyderabad on an air ambulance. Then within 4 days, he started to recover. Then AK started reversing, the shock recovered because it is purely a infection-related myocarditis leading into cardiogenic shock. So these are all reversible. What matters is the timing. The time when you initiate, whether it is reversible or not. That is what is important. And this is post-decannulation. His pressures were good, and then he started ambulating within a week. Then he was discharged after 7 days. So what is important is excellence in care is always about a team effort and proper planning. So why we are not using them? Because the first biggest challenge for us is the cost. The second is awareness, because most of us are not aware when to use, when not to use. Then the third is the time. Every time it may not be initiated, because whatever story till now I have told is only the success stories. There is always the other side of it which we would not be discussing, and the availability. And again, I would like to bring upon two important personalities, famous personalities. I think the right side person, everyone is aware. He is one of the minister in the last government, and he collapsed in his home. Both of them are so rich that they can afford anything. But when the time was there is no support for them. That is why they could not survive. So most of the time, ECMO would be needed in an emergency, and there would be a very limited time, and the challenges would be financials and the kit availability, because the kit is imported from the West. So obviously the kit availability, the machine availability, and the team availability becomes very important. So what are the financial challenges? When we talk, the circuit itself costs around 3.5 lakhs. So that is what we tell them upfront, and once they are ready, then we have to talk about all the complications. What are the risks? What are the benefits? Complications? What is the possibility of reversibility? And all these things. Then again, the biggest challenge would be ethical, social, and moral concerns, because most of the times the patients what we get are very young, but they couldn't afford. On the other side, there are patients who are very elderly, most of their, children would be in US or UK, where they will take time to come. So they want us to initiate the patient on an ECMO till they come. We all know that this patient is not going to survive. Then once we initiate ECMO, the problem comes in discontinuation. Are we allowed to discontinue? These are the ethical concerns which come into practice. Then indefinite continuing without any end goal. So are the insurance or the financial exhaustion, what to do next? So these are the moral issues which will come into picture. And I didn't show you any of the complications. This is a machine which will be considered as the highest life support possible. At the same time, it has got the highest possible number of complications which you have to understand, where limb ischemia is one of the most catastrophic complication, where the patients can lose limbs. Or bleedings, clots in the circuit, collapse, all this can happen in a fraction of a second. They can just collapse, was the circuit clots, that's it. So, my take-home message would be, see to believe, patients do survive after cardiac arrest. That is what is called an eCPR, which is very new in our country, which is very well organized in the West. So eCPR is potentially feasible, it is developing. Affordability obviously is a concern in India, and availability at the site of emergency, the right time, the right place, and the right referral is what matters. And awareness regarding the availability of these devices and support systems is very important. And we had a good number of case experience and cumulative experience of few hundreds of cases what we have done. And we all can together make a difference in saving lives. So I'll just briefly highlight some of the cases what we have done for transplant. This is a patient again on an ECMO. You can see a cannula going on the neck. And this is how we do prepare them prior to a transplant with a physiotherapy. So every case what we faced has some challenges. I'm not going to talk about the challenges. And this is how we, do a transplant in our center. Then another case, this is a paraquat poison. I don't know again whether how many of you have seen a paraquat case. It is a death sentence. Basically, any patient who comes with a paraquat sentence, the mortality is 100% and none of them treats. But this is a paraquat poison patient who has been initiated on an ECMO with a severe weakness, severe RV dysfunction, and this is how his RV looks like. It is grossly dilated, even before transplant. And this patient was transplanted and was successfully recovered. So this is a 68-year-old male, end-stage ILD, who has been transplanted and discharged within a week to the hospital. So again, there are different categories of patients who are recovering. This is on the first post-op day, post-extubation for a transplant, where we are making him to do a physiotherapy in the form of an incentive spirometry. And this is the discharge, pic. And this last case is a 12-year-old male, accidental ingestion of a paraquat, the world's youngest paraquat survivor post-transplant. He has undergone the world's first lobar transplantation, bilateral lobar transplantation, because we don't generally get pediatric lungs as a donor. So we have to get an adult lung, dissect them, put a lobe of the lung to transplant him. So this is the world's first, pediatric lobar transplantation. And this is what makes us happy. Post-lung transplantation, and this guy is running on the beach, who has a very bad X-ray pre-transplant, and this is the quality of life what they can enjoy. Thank you. I can take a couple of questions if there are any. Per se, cost doesn't differ between venous and veno-arterial, sir. Essentially, the machine and the circuit, everything is the same. The only difference is the blood, where it is diverted. It is not into the venous system, you are diverting it into the arterial system. So, the complication rate or the survival rate of a veno-arterial ECMO is much lower than the veno-venous. We all understand that veno-venous, the lung is the predominant culprit there. So we can always support the lung as much as possible, because we have ECMO patients for almost close to 57 days, 60 days on a veno-venous ECMO. On the other side, veno-arterial ECMOs, you cannot push them for such a long time, because the arterial cannula is in the aorta. So basically, you are retrogradely putting a cannula into the aorta, and the circulation is compromised to the limb. So you need to reperfuse that femoral artery through an additional cannula, which is a compromised circulation. So the more longer they stay on a veno-arterial ECMO, the more longer the probability of them developing some form of limb complications. So literature-wise, the survival of a VECMO patient is only 30% across the world. And again, it depends on the category of patient what you choose. You choose a patient with a peripartum cardiomyopathy or a patient with a viral myocarditis, the survival goes very high. But you choose a patient with an acute MI, with a multi-organ dysfunction, again, the timing of the initiation what matters. You initiate early, the survival rates are good. But you initiate them once they set into an AKA where they are dialysis dependent, then the mortality always goes low, goes high. The survival rate goes low.
Thank you, sir, for the informative session. Now, I request our organizing secretary, Dr. Arhan Sharan Jain, sir, to kindly felicitate Dr. V. Ravi Shankar with a shawl and a memento. Sir, please. Thank you, sir. Now we will start with our DNB sessions, for which we have 3 judges, and I would like to request Dr. Y.S. Parihar sir, ex-EDMS CIL, Dr. Ashok Sharma sir, ex-CMS ACCL, and Dr. M.T. Tikas sir, ex-CMS ACCL, to kindly come on the stage, sir. Sir, please.
In this August gathering, I welcome Dr. Mudgal sir and Mrs. Mudgal madam for gracing this occasion. Please, करतल ध्वनि से तो स्वागत किया ही जा सकता है, और ये अपने कोल इंडिया का मेडिकल फ्रेटर्निटी का प्रोग्राम है, इसलिए सभी से रिक्वेस्ट है कि सारे प्रोग्राम में खूब उत्साह के साथ तालियां भी बजाएं और इंटरेक्टिव सेशन भी रखें। ये डीएनवी सेशन भी इसीलिए रखा गया है, लोग सोच रहे हैं कि 3 सेशन है और अवार्ड है, तो जजेस को फर्स्ट सेकंड थर्ड ही डिसाइड करना है, पर इट्स अ प्राइड फॉर अवर कोल इंडिया दैट वी इन आवर हॉस्पिटल वी आर रनिंग डीएनवी कोर्सेज, सो दिस डीएनवी सेशन बिकम अ सक्सेस फॉर next CIMECON also, because in previous CIMECON they have put this category, so we have also incorporated this category.
For the first session, I would like to request Dr. Indrabhushan Singh, DNB Medicine, JR1 and Senior Medical Officer, BNK Area, CCL. The topic of the presentation is hemoptysis in a coal miner when tuberculosis is not the culprit. And I would also request our judges to kindly introduce the rules and regulations and the marking patterns for the session as well.
Hello. There are certain rules. There are 100 marks for the presentation, 40 marks for the content, and way of presentation, there are 30 marks. And then question and answer session, you will get 20 marks. In time management, there is a arrangement of 10 marks. Total marks will be 100 marks. Out of that, it will be decided who will be getting the prize out of it. Okay, thanks. You can go ahead with the presentation. The first candidate is Dr. Indrabhushan Singh. So, Dr. Indrabhushan Singh, you are requested to present your topic.
Good afternoon, sir.
Okay. So, 10 minutes for presentation and 5 minutes for question and answer. Okay, 5 minutes for question and answer. Total 15 minutes. So, Dr. Indrabhushan Singh, please present with your topic. Okay, you are there.
Good afternoon, Chairperson, judges, and seniors. I, Dr. Indrabhushan Singh, DNB Medicine, PG1, Central Hospital, and Senior Medical Officer, CCL, is here to present a case titled Hemoptysis in coal workers when tuberculosis is not the culprit. In India, hemoptysis is often equated with a TB, but in occupational history, we must evaluate other causes of TB also. My learning objectives in this case is approach to how to approach hemoptysis in coal workers, identify non-TB causes, recognize HRCT features of aspergillomas, and discuss management. My patient profiles, patients came with 61-year-old male retired coal workers came to CSD with a complaints of recurrent hemoptysis since 2 months. one episodes of hemoptysis around 100 ml 2 days ago. Coming to a history of present illness, the patient was apparently all right 2 months ago when he develops cough with expectorations with blood tinge and non-foul smelling sputum, gradually progressive in nature, which progresses to frank hemoptysis without any diurnal variations. Patients also complain of fatigue and breathlessness, which increases on exertions. Coming to a negative history, there are no history of acute high-grade fever with chills and rigors, no history of orthopnea, paroxysmal nocturnal dyspnea, and no history of recurrent pneumonia. No history of weight loss, night sweatings, and no prolonged history of steroid therapy, type 2 diabetes mellitus, hypertension, and thyroid disorders. No any history of pedal edema, recent travel to endemic fungal outbreak areas, and immunosuppressive drug intake, no history of hemoptysis, and no history of any anticoagulant use. Coming to a past history, patient has a history of pulmonary tuberculosis 8 years ago, completed full course of treatment. Coming to occupational history, a patient was a coal worker, worked for 32 years in coal mines. There are no significant family history present. Coming to a personal history, a patient is a non-alcoholic. Dietary history is a mixed dietary habits, adequate calorie intake, appetite was normal, bowel and bladder habits were regular. Sleep disturbed occasionally due to cough, no paroxysmal nocturnal dyspnea. Patient was a chronic smoker with 8 to 10 BDs per day for 20 years, coming to a smoking index of 200, which categorized as a moderate smoker. Coming to a physical examination, on general examinations, the patient is moderately built and nourished. Vitals were BP 130 by 90 mmHg, pulse rate 90 beats per minute, respiratory rate 30 per minute, temperature 98.1 degree, JBP normal, pallor positive, no clubbing, no cyanosis, no edema, and lymphadenopathy. No icterus were seen. Coming to a systemic examinations, on respiratory examination, on inspections, chest were bilaterally symmetrical, no visual scars, no dilated veins, no obvious chest wall deformity, and use of accessory muscles. On palpation, trachea centrally placed, reduced chest expansion in right upper zone, tactile vocal parameters slightly reduced in right upper lobe. On percussions, impaired dull or slightly hyper-resonant note in right upper lung field. On auscultations, reduced air entry in right upper lobe and coarse crepitation in right upper lobe. No bronchial breathing sounds and no amphoric breath sounds were present, and no pleural rub. On CBS examinations, S1, S2 heard and no murmur heard. On abdominal examinations, abdominals are soft, non-tender, non-distended, no organomegaly present. CNS, all higher mental functions are normal, conscious, patient conscious, alert and oriented, all cranial nerves intact. The probable differential diagnosis in this case may be reactivations of pulmonary tuberculosis, chronic pulmonary aspergillosis, cavitary bronchiogenic carcinoma, lung abscess, bronchiectasis, Rasmussen's aneurysm, coal workers pneumoconiosis with progressive massive fibrosis. Initial workup in this case is in patients, the hemoglobin is 8.9 gram per deciliter, hematocrit value is 34%, TLC count were 11,000 per millimeter cube, ESR were mildly raised. Then we performed a sputum for acid-fast bacilli and CBNAT, which comes out to be a negative. Then we performed a chest X-ray. On chest X-ray, we see a thick walled cavity in right upper lobe and intracavitary round soft tissues, opacity and surrounding air crescents. Then we confirmed chest X-rays with to narrow down our diagnosis with HRCT. In HRCT, there were thick walled cavity, intracavitary free soft tissue masses, and air crescent signs. So air crescent sign, also known as Monet sign, typical for aspergillomas. For confirmatory, we perform a serum aspergillus IgG antibody test, which comes out to be positive. And then sputum for fungal culture, in which we find out Aspergillus fumigatus, galactomannan test, which comes out a negative, and it's rule out invasive aspergillosis. Then the diagnosis part. My case is a pulmonary aspergilloma in post-TB TB cavity, and management in asymptomatic cases we observe only, and in mild to moderate cases of hemoptysis we give a Tranexa and consider antifungal agent as adjuncts, because antifungal agent can not directly cure the patient, but it can limit the surrounding spread, as voriconazole or itraconazole. Voriconazole is a P450 dependent inhibitors which inhibits lanosterol to ergosterol conversions and limit the damage the membrane integrity. The loading dose is around 40 mg BD and on maintenance 200 mg BD. On severe recurrent hemoptysis, we can consider for bronchial artery embolizations for temporary control, and the definitive treatment is surgical resections or lobectomy. Coming to a discussion part of case, aspergilloma is a saprophytic colonization of pre-existing lung cavity by Aspergillus species, that is Aspergillus fumigatus. Etiology may be post-pulmonary TB cavity, sarcoidosis, bronchiectasis, lung abscess, and cavitary malignancy. Types are simple aspergilloma, in which there is a single cavity, minimal surrounding disease, preserved lung functions. In complex aspergilloma, there are thick walled cavity and surrounding fibrosis and poor lung reserve. Take-home message for this case is not all hemoptysis is TB. Think aspergilloma in post-TB cavities and some other causes also. HRCT is a diagnostic, and avoid empirical treatment in any hemoptysis cases. Thank you.
Now you can ask question. It is audience to ask question now.
Sir, in the asymptomatic, the patient was symptomatic, but on adding sir, by Tranexa, the hemoptysis was controlled. But with further evaluations, we have referred for the higher centers also, sir. Follow-up, sir, the patient is on treatment of voriconazole to limit the spread, and bronchoarterial embolization was done, sir.
What work he was doing as a in coal mines? Patient, what work he was doing?
Sorry, sir.
Job of the patient you have taken.
Sir, patient was retired, sir, retired coal workers.
Retired as a clerk or as a coal miners?
Sir, coal workers, sir. Coal workers.
Coal workers. You cannot give the designation of the person.
Sir, category.
In coal mine, what work he was doing?
Sir, general assistant.
Now, what was the source of this bleeding or hemoptysis?
Sir, bronchial artery hypertrophy is the most common causes, and mechanical irritation due to fungal mass, sir.
Any questions?
Nice presentation, Dr. Indrabhushan. But do you think a thick-walled cavity in upper apical lobe of the lung will cause hemoptysis? Don't you think that we have to look for some other source of bleeding other than that cavity?
Yes, sir. According to differential, I took the history and I have ruled out accordingly history and HRCT findings. The HRCT is most probable showing, sir, indicating about the fungal masses, and confirmatory tests also confirm it, sir.
Okay.
I think there are unsupported arteries in the cavity. Even though there would not have been any fungal infection, it would have presented with the hemoptysis again. So, fungal infection may or may not be the cause for hemoptysis, I mean to say. What is your take on that issue?
Sir, there may be, sir, other causes can also be, sir. Cardiac causes can be.
Do you think there is erosion by fungal infection in that arteries particularly?
Yes, sir. So fungal mechanical irritation can happen, sir, due to mobility of the patients and fungal.
Can only antifungal treatment controls that one?
No, sir. Antifungal, sir, can limit the spread around the cavity, sir. That's why the voriconazole can be given to further limit the invasiveness of the case.
Have you tried for this one? Have you controlled all this hemoptysis, and what was the next step in your management?
Hemoptysis was controlled at the center, sir. Then we, for further intervention, we referred to a higher center. There bronchial arterial embolization was done, sir. And the patient is well controlled and under voriconazole treatment to limit the spread, sir.
Okay, thank you.
Excuse me, doctor. Good presentation. I have just one question. In your one of your slide, you have shown respiratory rate as 30.
Yes, sir.
Yeah. So whether the patient is suffering from any shortness of breath or not.
Sir,
you have also mentioned there is no accessory, in general survey you have mentioned that there is no accessory muscles of respiration.
sir, at that time, sir, patient was not suffering for dyspnea. So on exertions, there was a dyspnea, sir.
So you have recorded your finding in exertional dyspnea condition?
So, sir, at that time, the patient was not on exertions. So the respiratory rate was 30, sir.
So, okay.
Is there any question from audience?
Sir, we can, sir, definitive treatment is a lobectomy, sir. We can remove that lobe. Yes, sir, yes, sir. Yes, sir.
He meant to say the cavity will remain same and patient is again prone for same type of infection frequently. Most probably patient might having the immunocompromised status again because of aging factor or something else. Okay. Thank you. So it's a definitely good presentation. So next candidate is Dr. Shweta Singh. Dr. Shweta Singh, you are requested to present your case.
Good afternoon, chairpersons, CMSs, ex-CMSs, esteemed faculties and judges, and delegates from all subsidiaries. I'm Dr. Shweta Singh, DNB Medicine JR3 from Central Hospital Dhanbad and Medical Superintendent in the same Central Hospital Dhanbad BCCL. So I'm presenting a case on hypertrophic obstructive cardiomyopathy in young adults, why early diagnosis matter. A 25-year-old gentleman came to the CHD medicine OPD with chief complaints of dyspnea on exertion since 4 years, fatigability and exercise intolerance since 8 months, and occasional palpitation at rest since 2 to 3 months. Patient was apparently all right 4 years ago when he developed shortness of breath, dyspnea which increased gradually and progressively, nature from NIHA grade 1 to 3. Patient also complained of frequent fatigueness with ordinary activities as compared to his peers. Patient also experienced occasional palpitation at rest for the above complaint. He was evaluated elsewhere and found to have obstructive cardiomyopathy with 14% fibrosis and has come to us for further evaluation. There was no history of orthopnea, PND, no history of pedal edema, no history of any neurological deficits suggestive of embolic events, no history of any connective tissue disorder, no history of the syncopal attack, seizure, convulsion, fever, and no history of hypertension or any cardiac illness, including RHD and IHD. There was no history of thyroid disorders, no history of the chest trauma or prior cardiac surgeries. In the personal history, he was not alcoholic or any other cardiotoxic drug intake. Diet was mixed, appetite was normal, and sleep was adequate. The bowel and bladder habits were regular. There was no history of high-intensity athletic training or competitive sports. There was no history of over-the-counter stimulant or energy drink use. In the family history, there was no family history of sudden cardiac death in first or the second degree relatives. There was no family history of hypertrophic cardiomyopathy, dilated cardiomyopathy, or any other inherited cardiac diseases. There was no history of unexplained syncope or sudden death of a young age in the family, and no family history of implantable water defibrillator implantation. There was no family history of consanguinity. In the physical examination, general examination, patient was conscious, cooperative oriented to time, place, and person. He was moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, and lymphadenopathy or pedal edema. Jugular venous pressure was normal. There was no skeletal deformities. The pulse was 89 beats per minute and the normal in volume, regular. Peripheral pulsations were palpable. The blood pressure was 120 by 80. Respiratory rate was 16 per minute. SpO2 99% on the room air. In the cardiovascular examination inspection, we see the pericardium appears to be normal with a visible apical impulse, no visible pericardial bulge or dilated vein, no visible pulsations in the suprasternal or the epigastric region. In the palpation, apex B, it was localized in the fifth intercostal space, just medial to the midclavicular line, forceful, sustained, and localized, double apical impulse palpable. Parasternal region, no parasternal heave, thrill, systolic thrill felt at the lower left sternal border. In the peripheral pulsation, pulse characters appear normal or peripheral pulses palpable and symmetrical. On the auscultation, S1, S2 heard murmur. There was a harsh ejection systolic murmur held at the left lower sternal border. In the respiratory system, inspection, chest was symmetrical, no use of accessory muscle of respiration, no intercostal retractions or the chest wall deformity was there. Palpation trachea was centrally placed. Chest expansion bilaterally equal, vocal fremitus was normal, percussion resonant node heard bilaterally, auscultation vesicular breath sounds heard bilaterally, no added sounds like repetitions, wheeze or rhonchi was present. In the abdominal examination, abdomen was soft, non-distended, no visible veins or scars. On palpation, there was no hepatomegaly or splenomegaly. On the percussion, normal liver span, no shifting dullness was present. Auscultation, the normal bowel sounds were present. No evidence of any systemic venous congestion. In the central nervous system, higher mental function was, he was conscious, alert, oriented. Cranial nerve, all cranial nerves were intact. Motor speech, normal muscle, bulk and tone power 5/5 in all the limbs. Deep tendon reflexes were normal. Plantar reflex was flexor bilaterally. Musculoskeletal system, there was no muscular wasting. No joint swelling or any other deformity was present. In the ECG findings, shows left ventricular hypertrophy, high voltage QRS complex with S in V1 plus R in V5, V6 more than 35 millimeter, tall R waves in V4 to V5, deep S waves in V1 to V3, and there was left axis deviation and P mitral A. In the echo, there was HOCM features with dilated LA, mild MR, and the normal LV systolic function, no RWMA, and TR was traced with grade 2 diastolic dysfunction with normal left ventricular function. There was no clots vegetation and no pericardial effusion. Play नहीं हो रहा. प्ले क्यों नहीं हो रहा? In the echo, we find it that there was massive hypertrophy of the left ventricular septum, parasternal long axis in the and parasternal short axis views, and there was end diastolic frame with maximal septal thickness of around 38 millimeter. There was systolic anterior motion of the anterior mitral leaflet with grade 3 with increased color turbulence noted across the left ventricular outflow tract. There was no significant left apical gradient and dilated LA with volume 202 ml. Following echocardiography, patient was referred to CMC Vellore for further cardiac evaluation and cardiology opinion and management, and he was advised medication of metoprolol, XL50 mg BD and tablet chlorthalidone 6.25 mg BD. At CMC, patient was admitted for the CAT study and evaluation of HOCM. He underwent transradial coronary angiography and transfemoral LV angiogram with peripheral angiography, which shows normal epicardial coronaries and mid-cavity HCM with concentric LVH. 24 hours Holter monitoring was initiated. In the view of the mid-cavity HCM, relatives were told to be on the medical management at present. Will review with cardiac MRI Holters. Patient monitored, medication optimized, gradually mobilized and discharged in a hemodynamically stable state with recommendation with restricted activities. Conclusion, why early diagnosis matters in young adults. Hypertrophic obstructive cardiomyopathy in young adults is a potentially life-threatening but often underdiagnosed condition due to its variable and sometimes subtle clinical presentation. Early diagnosis is crucial as SOCM is one of the leading causes of sudden cardiac death in young individuals, particularly during exertion. Timely identification allows for early initiation of the medical therapy to relieve symptom and reduce LVOT obstruction, risk satisfaction and prevention of the sudden cardiac death through appropriate surveillance and intervention. Lifestyle counseling and restriction from high-risk physical activities, screening of the first-degree relatives, enabling detection of the asymptomatic disease. This case highlights the importance of maintaining a high index of suspicion for HOCM in young patients presenting with exertional symptoms or unexplained syncope. Early diagnosis not only improves symptom control and quality of life, but also plays a pivotal role in preventing catastrophic outcomes, emphasizing the need for awareness and proactive evaluation in the high-risk population. Thank you, sir.
So, forum is open for open questions. Audience, please, you can ask question.
Yes, sir, we have done the ECG. ECG, sir, we have not put the ECG. Yes, there was LV strain pattern in that. Left ventricular hypertrophy was there. And echo we did, sir, at our center. Aortic stenosis, sir. Aortic stenosis also present with that ejection systolic murmur, sir.
What else? At lower left sternal border. Aortic stenosis murmur usually loudest at second.
To the carotid also. So, we suspected, we have done the echo, sir. Echo video was also there, but it couldn't be played. ECG was also there, sir. But it just had that left ventricular hypertrophy.
And what is dynamic auscultation and why you have not shown anything and you have not mentioned anything about dynamic auscultation in this patient? Because it is almost diagnostic clinically. What is dynamic auscultation?
Dynamic auscultation.
Anybody? You can go ahead with the questions. Yes.
How you have evaluated their relatives, blood relatives for CHON?
Sir, pardon, sir?
How you have evaluated their relatives that they are not having the cardiomyopathy?
Sir, by
It is just by history or they have undergone ECG or echo?
By echo, sir. We have actually advised them to go for the echo so that we can see whether there is some hypertrophy or not.
Why it cannot be Yamaguchi syndrome?
Yes, sir?
Yamaguchi syndrome.
Yamaguchi syndrome.
Do you know it has got a genetic preponderance?
Sir, actually there is asymmetrical hypertrophy and it is seen in young adults. So there is high degree of suspicion for HOCM.
Your patient was a young patient.
Yes, sir.
And it can occur with young patients most commonly because of the genetic disorder, which is Yamaguchi syndrome.
Sir, but that is not what we commonly see in day-to-day practices. We are only thing that revolves under our mind is hypertrophic cardiomyopathy. So high degree of suspicion landed into HOCM only, and by echo it was confirmed. So we never thought of something that is odd or commonly heard things we have actually given in the DD, and it has proved to be the same. So we didn't think about that.
Again, your patient was young.
Yes.
Why you have not thought about the stress-induced cardiomyopathy or Tokosubu syndrome?
Because it was like, the chronicity was there. So if it was stress-induced, it would be acute. So if it is the chronicity, it has been for the 8 months he was experiencing dyspnea.
How you have differentiated these two syndromes? In this case, how you have differentiated from that?
Actually, there is a SAM, that is systolic anterior motion of the leaflet is there, and we have taken that left ventricular outflow tract gradient, and the left atrial got dilated. That will be chronically, it will get dilated. In acute condition, it cannot dilate overnight. So we didn't think about any stress induced.
Okay, anybody else?
Yes, sir. Yes, sir. No, sir. He might be coming, sir, but he doesn't. He has not come to us. For 4 years, he might be having slight dyspnea, and the grading of the dyspnea might have increased. And for 8 months, he was experiencing dyspnea of the grade 3. So maybe he would have gone to some other centers. He came to our CHD OPD because he was a dependent. So he might be having education somewhere. When he came to us, the symptoms were exacerbated from 8 months. And slight dyspnea, because the history what they give is vague many a times. Many a times the symptom are, but we will neglect why dyspnea, like we also neglect ourselves. So he might be also neglecting the symptoms. And when it has hampered his day-to-day activities, or it would be more, so he has turned to the hospital, because nobody wants to come to the hospital if it is not more symptoms is there. Huh? No, he was, his father was working. He was a dependent. That guy was a dependent.
Had patient responded to your treatment?
Sir, actually, when he turned, he was sent because CMC Vellore is their favorite choice if we utter something like some cardiac problem is there. So he went to CMC Vellore, and there he had all the halters, because at our center, we don't have halter. मशीन ज़्यादातर खराबी है, तो सर वो CMC क्योंकि जाना है, सारा टेस्ट कराना है, तो CMC गया सर, वहाँ पे उसका कार्डियक MRI वगैरह भी हुआ सर, लेकिन वो रिपोर्ट हमारे पास नहीं है, हॉल्टर वगैरह भी हुआ, और वहाँ से उसको मेडिकेशन में ये मेटोप्रेलॉल सर और CTD मिला, तो वही मेडिकेशंस फिर वो कंटिन्यू कर रहा है.
Is he responding well with the treatment, medical line of treatment?
यस सर, अभी वो ठीक है, और वो बाकी का जो रिपोर्ट है MRI वगैरह का वो वेटिंग है सर, मतलब अभी दिया नहीं है पेशेंट ने कार्डियक MRI का.
Okay, thank you.
थैंक यू सर, थैंक यू सर.
So next candidate is Dr. Ganesh Sapkal.
Good afternoon, respected judges, all the senior faculty, and my colleagues. Myself, Dr. Ganesh Sapkal, first year DNP resident from JNH Ranchi. Today, the case I am presenting is a case of hyperosmolar hyperglycemic non-ketotic state with hyponatremia and hypokalemia. So, coming to the case abstract of my case, this is a case of 62-year-old male who is a retired employee of CCL. Who admitted to JNH Ranchi EMU with complaints of loose motion, vomiting, fever, and ultrasound past 6 days. He was known case of type 2 diabetes mellitus. And I will explain all the history and complaints later on further slides. So my learning objectives here in this case are how to approach ultrasensorium in diabetic patient, how to differentiate this case with diabetic ketoacidosis and septic encephalopathy or stroke, explaining why hypernatremia is unusual in HSS and why this case is different, performing key calculations such as corrected sodium, effective osmolarity, and free water deficit, how to deliver our ICU management, how to give fluids, how to correct potassium, how to give insulin with targets and set targets and monitoring, and preventing complications which are associated with condition itself and the treatment given. So how we are going to approach is to know about patients, investigation done, coming to the diagnosis, then treatment and monitoring. So chief complaints of my patient was having loose stool for 6 days, vomiting for 3 days, fever for 3 days, progressive diagnosis and ultrasensorium since last 24 hours. Generalized weakness and oral intake was there since last 6 days. Coming to HOPI, the patient was apparently well 6 days prior to the admission when he developed multiple episodes of loose stool, watery, non-bloody, non-mucous, frequency 3 to 4 per day, associated with reduced appetite and decreased oral intake. Over next 3 days, the patient also developed vomiting, non-bilous, non-bile stains, 3 to 4 episodes per day, resulting in further reduction of oral intake. Around the same time, he developed fever for 3 days, low-grade, intermittent, associated with chills. During this illness, the patient had progressive generalized weakness, marked thirst, there were signs of dehydration, and prior to the admission, attendance noticed altered sensorium, and he came to our emergency. So coming to the negative history, I'm just saying, stating the positive findings. About the patient, there was no significant past history or family history. He's a patient. I have attached one photo of him. On general examination, the GCS was 12 by 15, oriented, he was disoriented to time, place, and person. Airway was patent. His pulse was 118 per minute. Blood pressure was 90/60, and there was postural drop present. Supine it was 90 to 60 millimeters of mercury, and on standing it was 90 by 50. Respiratory rate was around 20. Temperature was febrile, 38.6 degrees Celsius. Positive finding here in this case was skin turgor was reduced, eyes sunken, axilla dry, and capillary refill time was 3 seconds. Extremities were cold, and other findings were normal. On systemic examination, the patient pulse was tachy, regular low volume pulse, 30 pulse. There was no murmur JVP. On JVP not raised. On CNS, he was drowsy, disoriented, moving all 4 limbs, but there was no focal neurological deficits. Plantars were bilateral flexors. No meningeal signs were present. So, how I approach this case in our ER that I have shown. And these are the all investigation, and I have put why that investigation is done in this case. Coming to my differentials, the key differentials in this case were HHS, hyperosmolar hyperglycemic state, otherwise decay or mixed decay, sepsis, encephalopathy, and stroke. So how to differentiate? There were 2-4 main investigation, which were ABG, urine ketones, effective osmolality calculation, if there was crucial breathing or not, or if there was focal deficit, which was seen by or confirmed by brain imaging. So I have added one table, how to differentiate DK and HSS. The case reports here was that the WC count was elevated, which was suggestive of infection. Sodium was 164 milliequivalent per liter. RBS on admission was 594 milligram per deciliter. Potassium was 2.7 milliequivalent per liter. Urine sodium 57, potassium 15, and osmolality was 496. Urine glucose was present. These are the investigation reports of him of our hospital, which I have attached. In right lower quadrant, you can see that the CT brain was normal. The key calculations which we have done here is that calculating effective osmolality, which was around 361, which was very high compared to guidelines, what guidelines says. Corrected sodium was around 172. Calculated serum osmolality was around 376. And free water deficit, which I calculated with this formula, was around 7 liters. Coming to the knowing my topic, HHS. HSS is mainly a free water deficit disorder where we see a severe hyperglycemia, hyperosmolality, and dehydration with minimal or absent ketosis and no significant acidosis. Typical criteria includes glucose often more than 600 mg per deciliter, effective osmolality more than 320, pH more than 7.3, bicarbs more than 18, small or absent ketones. Here we see mortality is more than decay, and due to older age and comorbidities which are seen in elderly patient. So coming to the pathophysiology, so what happens here that there is relative insulin deficiency, but what happens in ketosis that there is much more insulin deficiency, that lipolysis is also, there is lipolysis, but in HSS there is enough, there was insulin deficiency that suppress glucose uptake, but there is enough insulin that, that does not cause lipolysis. So also there is glucosuria, which is extending the renal threshold, causing osmotic diuresis, resulting in water loss and electrolytes. What happens here is that rising osmolarity pulls up water out of neurons, causing neuronal shrinkage. Clinically, what we see that the patient having confusion, seizures, or coma. Severity can be tracked by measuring serum osmolality. So what our goal here is to gradual osmolality reduction and to avoid cerebral edema. So how osmotic diuresis causes dehydration, which I have shown in this slide, that the filtered glucose exceeds reabsorption threshold, causing glucosuria. Glucose acts as the osmolar, pulling water and sodium along with it. And adding vomiting and diarrhea, which we have seen in this patient, causes extreme hypotonic fluid loss, and urine indices reflecting on osmotic diuresis. So what happens in typical HSS that we see sodium that is low or normal, because what happens is that hyperglycemia causes osmotic water shift from ECF to ICF to ECF, but which dilutes serum. So there is a dilutional hyponatremia. But in this case, why hyponatremia has occurred, that there was prolonged osmotic diuresis, glucose causing severe water loss. There was concurrent vomiting and diarrhea, causing additional hypotonic fluid loss. There was poor intake and impaired thrust in elderly patient. So no replacement, patient presented late. So all this delayed presentation, all these factors result in hyponatremic hyperosmolar HSS. which has a very high neurological risk and mortality. So implications of hyponatremia HSS that worsens hyperosmolality and deepers altered sensorium. It is a marker of severe dehydration and delayed presentation. It alters our fluid strategy. So we are having strict correction rates here. That's we have to lower sodium by 0.5 milliequivalent per liter per hour and 10 to 12 milliequivalent per day, and decrease in osmolality should be around less than 3 per hour. Potassium depletion is commonly seen in here, so insulin must be delayed if potassium is less than 3.3. What to do differently in such cases? We have to treat it as a severe water deficit emergency, and after giving initial NS bolus, 0.9% LS bolus for reperfusion, we have to earlier shift to the half NS. We have to monitor glucose. When glucose is down, we have to avoid rapid glucose falls to prevent patient from getting into cerebral edema. We have to consider thromboprophylaxis because in such cases there are high risk of thrombosis as there is hemoconcentration. So this was a management overview which I have attached with this slide. So on phase 1, we have to do intravascular volume resuscitation, where we have to make a patient hemodynamically stable. Hence, we start with 0.9% saline, 1 liter per in first hour. And when the patient is hemodynamically stable, we shift to the half NS with target of providing free water. If typical rate is around 250 to 500 ml per hour, and we have to also start glucose, but if potassium is correct. Targets for safe correction, which I have earlier said, glucose fall is 50 to 75 milligram per deciliter per hour. Osmolality fall should be less than 3 milliosmolar per kg per hour, and sodium fall should be less than 0.5 milligallon per liter per hour. So why potassium is critical here? That the potassium, we have to delay potassium replacement only if it is more than 3.3. We have to give insulin only if potassium is more than 3.3. We have to hold insulin below that level and give potassium supplements. Insulin therapy is, we will give is around 0.05 units per kg per hour, and we have to, we don't give bolus here to prevent osmolality drops, and when glucose is around 250-300, we add dextrose to prevent complications such as cerebral edema. ICU monitoring checklist, which I had, we have to do hourly glucose and vitals monitoring, electrolyte monitoring, and strict input-output, and watch for sepsis and triggers. These are the complications associated with this condition. Treatment related are cerebral edema, osmotic demyelination, hypokalemia arrhythmia, and thrombosis AKI. With this treatment, the patient gradually improved his sensorium, and as I said earlier, that delayed presentation and severe symptoms cause this patient to be having a hyponatremic, hyperosmolar, hyperglycemic state. So rapid pulse, just all this, all those we have discussed. Thank you.
Okay, the forum is open for question answer session. From audience, it is expected to ask some questions.
Sir, first we see what is the concentration of half NS, which is around, it is around 77 milliequivalent per liter. So with that, we check how much expected sodium change will be there if we give half NS. So with 1 liter of half NS, in this patient, what we calculated that there was an expected sodium change of around -2 milliequivalent per liter. That is 2 milliequivalent per liter will decrease sodium with 1 liter of half NS. So, and according to criteria that we have to decrease his sodium by 8 to 10 milliequivalent per day, we give, so the calculation came around 4 liters of half NS, but such cases are not dealt with only what calculation says, because at the same time we are also giving him oral fluids, also free water by NG tube and NG tube also. So that also causes decrease in sodium, but it gives us a general idea. So this much fluid will be required. Sir, preferred preferred route if it is less than 2.5 milliequivalent per liter, and asymptomatic with less than 2.5, and if it is symptomatic, then more than 2.5 but symptomatic, then we give IV potassium, and if not, then we give oral supplements, and if we have to give more, then central line is preferred, and yes sir. Sir, lab culture was sent initially because we suspected that it is a case of septic encapsulation. So, but as you know, okay, lab cultures takes time, and patient already recovered from our treatment. That we already considered it that the patient is of HHS, and patient was even discharged, but that report did not came. So that. Sir, patient was a retired employee. Procalcitonin was written on first or second day, but as it was a test was costly, so patient refused for Procal. Yes, sir. Yes, we considered it. Yes, sir. $600, yes, sir. Was 594, sir. Yes, sir. Yes, sir. It was not typical classical of HHS, but yes, it was combination of both. Yes. Yes.
Was your hypernatremia corrected with the half saline?
Yes, sir.
How much time you require to correct hypernatremia?
Sir, we took almost 3 days, sir, because it was around, our target was to correct almost 8 to 8 milliequivalent per day.
Meanwhile, what was the condition of hypokalemia?
Sir, first we started with IV KCl infusion. So we followed the protocol, and later shifted patient to IV potassium to oral potassium supplements, and along with that we also gave insulin when his potassium recovered.
Was insulin going on at that time?
Yes, sir. Insulin.
He was on insulin. What was the condition about this correction of potassium because of addition of the insulin?
Sir, insulin causes intracellular shift of potassium. So we have to consider that also, that once we start insulin, there will be marked reduction in potassium. So we supplement potassium considering that also.
So little bit higher potassium you have supplied?
Yes, sir. Yes, sir. Our target was around 4 to 5.
Okay. Was it corrected?
Yes, sir. It was corrected.
What was the time for correction?
Sir, patient was eventually it was around 3 to 4 days took patient. On third day, his potassium was around 4 or 5.
Had your patient suffered with any neurological deficit?
No, sir. No deficit. His sensorium improved. First, he was came with altered sensorium, but later his sensorium gradually improved.
Okay, thank you.
Thanks.
Thank you, sir. With this, we have come to the end of our DNB session. The results for the same will be announced in the valedictory ceremony. Now I request Dr. VL Dhan ma'am, CMS and AMO Gevra area to kindly felicitate our esteemed judges. Ma'am, please. sir. Thank you, ma'am. Now we will have a short break of 10 minutes for high tea, and then we'll be continuing with our case presentation session.
लोग हैं जिनका साइंटिफिक कमेटी ने सिलेक्ट किया है, हमारे अपने ही बीच के लोग हैं, दोज हु आर प्रेजेंटिंग देयर फ्री पेपर्स और केस प्रेजेंटेशंस. So it is our moral duty also to support them. Everybody is requested to kindly seated, have a tea with your tables rather than gossiping and listen. It is really my humble request to please have a seat and for the success of next scientific session.
For judging the presentations, I would like to invite Dr. Minakshi Dev ma'am, ex-CMS ACCL, and Dr. S.K. Mudgal sir, ex-CMS ACCL, to kindly come on the dais, sir. Sir, please. Ma'am, please. And for the first session, I would like to invite Dr. Arijit Banerjee, Medical Superintendent, Sanctoria ECL. The topic of the presentation is fatal leptospirosis mimicking alcoholic hepatitis in a patient with chronic alcohol use disorder. Sir, please.
Hello, this is Dr. Arijit Banerjee, Medical Superintendent, Department of Medicine, Sanctoria Hospital, ECL. His case presentation is fatal case of leptospirosis mimicking alcoholic hepatitis in a patient with chronic alcohol use disorder.
Respected judges, my seniors and my dear colleagues, today I'm here to present a case of leptospirosis mimicking alcoholic hepatitis in a chronic alcohol use disorder. So leptospirosis is a re-emerging zoonotic infection caused by Leptospira spirochetes, transmitted mainly through water and soil by contaminated rodent urine. While it is often a cell-limited febrile illness, the icteric form called as the Wheels disease can progress rapidly into a organ failure with high mortality rates. In patients with chronic alcohol use, the diagnosis is frequently overlooked and misdiagnosed due to overlapping clinical features like jaundice and renal impairment. This patient, a 36-year-old male security guard with a history of chronic alcohol use of almost 20 years, he started drinking at the age of 16 with frequent previous admissions in the hospital for alcoholic hepatitis, alcohol dependence and withdrawal, and he had an existing differential diagnosis of hepatic cirrhosis. But this time, he was admitted with a 7-day history of fever, generalized myalgia, cough pains, and with a history of decreased urine output and black stools. On admission, he had tachycardia, BP of 120/70, and saturation of 94%. So, initial hypothesis was, since he had symptoms of jaundice, ascites, and alcohol history, and tender hepatosplenomegaly, lab report showed a AST-ALT ratio of 1.66. Working diagnosis was acute on chronic liver failure or alcoholic hepatitis, and started on IV fluids, thiamine, paracetamol, and broad-spectrum ceftriaxone. But his lab reports said something else. His baseline TLC was 20,000, which increased after 3 days. The bilirubin levels was 4, which increased in the due course of time of the next 7 days, and creatinine levels also kept on rising. So we modified the treatment and replaced ceftriaxone with meropenem 500 according to renal dose, and gave some hepatoprotectives like L-ornithine, L-aspartate, adimionine, and glutathione. We digged deep into the history and found out that he was a resident of nearby river belts, had proximity to river fields, rice fields, and had exposure of rats with poor hygiene. We had sent parameters. So something clicked in our mind, fever not subsiding, rising sepsis, what can be the cause? So we sent for inflammatory markers and sent for leptospirosis along with the hepatitis for fever. So the culprit came out to be positive, leptospira IgM on day 4. It came out to be positive, and we modified our diagnosis as sepsis, multi-organ dysfunction syndrome, while the other viral markers were negative. So we started a clinical targeted therapy. Along with meropenem, we started doxycycline, supportive NORAD, solumedrol, and terlipressin for his low BPs, and continued the supportive hepatoprotective measures of glutathione and LOLA. But there was a fatal twist. After starting doxycycline, he suffered history of fever chills, his symptoms deteriorated, tachycardia, myalgia, nausea, vomiting, pain abdomen increased, and he developed a Jarisch-Herxheimer reaction. It is a well-known reaction due to the spirochete lysis due to initiation of targeted therapy, which causes release of endotoxin and cytokine storm, leading on to septic shock. The lab trends kept on increasing, and there was a leukemoid reaction by the end of day 15 with 2,000 counts, and the bilirubin kept on rising, and there was fluctuation of the creatinine levels. CRP and procal also was increased. We did the prognostic markers, and all were poor. His MEL score predicted a 52% mortality. MADRI score predicted a poor prognosis, and even steroids were not helping at this point. So there was a system collapse, and the chain reaction continued. Ultimately, he was referred as he required dialysis, and he succumbed to his illness due to septic shock, coagulopathy, hepatic failure, respiratory failure, and kidney failure. So here I would like to draw a conclusion to our physicians that there must be some psychological biases. One is the anchoring bias. We locked onto the alcoholic label and did not look around the infective cause, which may be missed. And also some uncommon things also we should think out of the box, and premature closure should be avoided. There is difference between alcoholic hepatitis and leptospirosis, where there is conjunctival suffusion, and the canicular disruption is the main pathophysiology behind leptospiral liver injury rather than hepatocellular injury as seen in alcoholic hepatitis. So the clinical takeaways is high clinical suspicion whenever there is fever, sepsis, and acute hepatic failure. Alcohol can be a pro-inflammatory amplifier, clinical mimicker, and immune suppressor. And empirical treatment should be started as soon as possible to avoid acute multi-organ failure. These are my references. Thank you.
We must congratulate you on the early diagnosis of this leptospirosis mimicking chronic alcoholic abuse. So, any questions from the audience? I would like to ask you one question.
Yes, ma'am.
How did you think of leptospirosis in this case? What was the main criteria, in the investigations?
Ma'am, in spite of all the baseline investigations, there can be
only one criteria.
The history.
History, I'm talking about the biochemical tests.
Yes, ma'am.
Yes, the blood test. The renal failure was severe in comparison to the liver injury, I think.
Yes, ma'am. The triad of renal failure,
and
liver failure,
that
jaundice.
That is why you differentiated from alcoholic hepatitis.
Yes, that is the Wheels triad.
Right.
Thank you so much.
Thank you, sir. Next speaker, Dr. Satish Maravedi, Deputy Medical Superintendent, Orient MCL. His topic is silicotuberculosis in a coal miner.
respected dignitaries, judges, senior doctors, friends and colleagues, myself Dr. Satish, I am from Mahanadi Coalfields Limited. I am here to present silicotuberculosis, the deadly synergy where silica exposure means tuberculosis infection. Way back in 2022 when I was working in Singareni Collieries Limited, I have come across this kind of patient, so I would like to present that case. Patient details include the patient 59-year-old male, underground coal miner for about 30 years of exposure, known case of type 2 diabetes, mellitus and hypertension, and he is a known smoker. He came up with the chief complaints of productive cough for 2 months, fever with night sweats since 1 month, and significant weight loss for about 6 kg for 1 month. The present history includes the patient developed persistent productive cough associated with evening rise of temperature and night sweats. Symptoms progressively worsened over 2 months with marked weight loss and increased fatigue. Past history was 30 years underground coal mine exposure, no prior documented ITT therapy, no previously diagnosed chronic lung disease. Treatment history on oral hypoglycemic agents for type 2 diabetes, on antihypertensive medications, no prior ATT. Personal history is a chronic smoker, irregular use of respiratory protective equipment during service. Depending on the symptoms presented by the patient, chronic productive cough for about 1 month and weight loss, then I have made up a provisional diagnosis of pulmonary tuberculosis on background of occupational lung disease. And I have advised him some investigations like CBP, HbA1c, LFT, RFT, viral markers, chest X-ray, CBNAT, just to look at the HbA1c for sugar, look for the sugar control, LFT, RFT for the status of kidney and liver, viral markers. Then CBP showed mild anemia, HbA1c was elevated. Chest X-ray showed bilateral opposite nodular opacities, XL calcification and hilar lymph nodes. CBNAT shows MTB detected rifampicin sensitive, and discussion with senior doctors, we have made up a diagnosis called silicotuberculosis, a chronic silicosis with superimposed pulmonary tuberculosis. This case was referred to higher center for treatment. The treatment modality consists of standard HRZD regimen, optimization of glycemic control, and the patient has been counseled regarding the smoking cessation, nutritional supplementation, removal from further silica exposure, supportive pulmonary care, and monitoring for complications. Regarding the silicotuberculosis, I would like to discuss regarding the silicosis, what is silicosis and what are the pathophysiological features of silicotuberculosis, and what are the preventive measures should be taken to control the silicotuberculosis. Silicosis is also known as grinder's disease or miner's disease. The definition is active TB occurring in a patient with established silicosis. It is a synergistic condition caused with the dual impact of inhalation of silica dust and infection of TB bacteria. As you can see, there is a synergy, which is deadly synergy. From gold mines to designer jeans, historical origins of silicosis, first reported at Kolar goldfields. Classical risks may be glass manufacturing, quarry working, stone cutting. The modern outbreaks are denim jeans sandblasting. People working in denim jeans sandblasting to make it fade out look, and people working in kitchen countertop stone manufacturers. People working in these kind of factories are more prone to silicosis, and they might be ended up in silicotuberculosis. These are the modern outbreaks, and silicosis is a pre-malignant condition. The pathophysiology is a biological cascade. Silica dust of 0.5 to 5 microns. When deposited in the alveoli, phagocytosed by alveolar macrophages, there occurs the impaired cellular mediated immunity, decreased macrophage bactericidal activity, unable to kill TB bacteria, and the activation of latent tuberculosis causing silicotuberculosis. On the other hand, release of mediators causing fibroblast activation and causing pulmonary nodular fibrosis. The diagnostic triad includes history, occupational exposure, microbiological confirmation of TB bacteria, radiology, nodular fibrosis, and XL calcification. The ALV classification standard is a worldwide standardization of chest X-ray reporting in pneumoconiosis. It is an epidemiological test, not strictly a diagnostic test. As per silicosis, rounded nodules are seen in the upper lobes. Codes were made by PQR, and it comes under the category A. Radiological signals of silicosis include the XL calcification. In the acute silicosis condition, there is a crazy paving pattern. Generalized conditions are upper lobe nodular fibrosis. Differential diagnosis silicosis also shows no stem pattern. Like it is also seen in can mimic miliary tuberculosis, also can mimic pulmonary alveolar proteinosis, can mimic chickenpox, pneumonia can also mimic. Management protocol principle is treat both the problems simultaneously. Immediate action, remove from silica exposure. The infection standard anti-TB therapy as per NTEP National Tuberculosis Elimination Program. The fibrosis supportive care should be given, pulmonary rehabilitation, monitor complications. There is no cure for silicosis itself, and high prevalence in India. Among silicotic patients, silicotuberculosis prevalence ranges from 5% to 25%. Prevention is the only cure. From the engineering side, dust control measures in mines and factories should be taken. Medical surveillance, periodic screening of workers, prophylaxis, isoniazid preventive therapy for high-risk groups. Key takeaways from this case, the threat, silico-2B is a deadly synergy of silico exposure and TB infection. The new vectors are beyond mines. Watch for denim sandblasting and artificial stone. Radiology, look for XL calcification on X-ray, crazy paving CT, and microscopy. On polarizing microscopy, there is a birefringent silica. Urgency treatment response is very poor. Prevention and early screenings are paramount. This slide shows the total silicotuberculosis pathophysiology and prevention and treatment. The cause, dust, infection, result, relapse rate is higher, treatment response is poorer, respiratory progression is faster, and at a detection includes occupational history, microbiological confirmation, radiology, XL calcification, and the action includes prevention is the only cure, modern risk beyond the minds. Thank you.
Thank you, Dr. Satish.
Ma'am, thank you, ma'am.
Any questions?
Sarcoidosis. Sarcoidosis is not the primary diagnosis. It is diagnosed on the diagnosis of exclusion, right? So this might not come under sarcoidosis. Ma'am.
Okay, thank you.
Thank you, ma'am.
Next speaker, Dr. Kalol Bhaumik, Senior Medical Officer, Sanctoria ECL. His case report is on erythrodermic psoriasis.
Good afternoon, judges and all delegates. I am Dr. Kalol Bhaumik, Senior Medical Officer, Sanctoria Hospital, ECL Headquarters, going to present erythrodermic psoriasis rare case presentation. Complaints and present illness: a 31-year-old male presents with redness, scaling and itching all over the body since 2 months. Patient was apparently asymptomatic 2 months back. Then he developed erythema and scaling over trunk, extremities, faces, neck, scalp, and also including palm soles with itching. No history of joint pains, no history of fever and chills. Past medical history: patient is a known hypertensive since 3 to 4 years on irregular medication. Known case of psoriasis since 10 years, no history of diabetes mellitus, TB, asthma, epilepsy. Family history of psoriasis present. Personal history: appetite normal, sleep disturbed, diet normal. On examination, patient alert, conscious, cooperative, blood pressure 130 by 90 millimeter mercury, pulse 84 per minute, pallor mild, temperature afebrile, bilateral lymph nodes not palpable, edema, bilateral pedal edema present, jaundice absent, chest bilateral clear, CBS S1, S2 plus, abdomen soft, non-tender. Cutaneous examination: bilateral symmetrical diffuse erythema, scaling associated with itching present over trunk, face, scalp, all extremities. Palm soles were also involved. This is day 1 and presentation. Patient presents with this, and after getting treatment, the picture is this. Complete blood picture: hemoglobin 8 gram%, TLC 13,000 cells per cubic millimeter, neutrophil 68%, lymphocyte 28%, eosinophil 2%, monocyte 2%, platelet 250,000, ESR 25 millimeter per hour. Laboratory data: 80 milligram per DL, serum electrolytes: sodium 128 milliequivalent per liter, potassium 4.6 milliequivalent per liter, serum protein 7.8 gram per DL, serum albumin 2.8 gram per DL, albumin globulin ratio 1.8. Dermatological consultation taken and skin biopsy advised. I have gone for skin biopsy. There is regular acanthosis on epidermis, perivascular infiltrate on lymphocytes and eosinophils, dilated tortuous capillaries within the dermal papilla, perivascular infiltrate on lymphocytes, eosinophils and neutrophils. There is pustules of Kogos. Differential diagnosis: lichen planus, erythrodermic psoriasis, atopic dermatitis, erythema multiforme, Steven-Johnson syndrome. Why this is erythrodermic psoriasis? It is associated with discourse, scaling, classical plaques of psoriasis over his elbows, scalp scaling, history of psoriasis, family history. There is severe pruritus and fever. Erythrodermic psoriasis, it is there is lower extremity edema is common, high output cardiac failure and impaired hepatic and renal function may also occur. Management, bed rest, IV fluids, emollients, topical steroids, weight dressing, systemic steroids, pulse therapy, diuretics. Specific treatment may be given acetretin, cyclosporin A, DMRD, PUVA, NB-UVB, oral retinoids, anti-TNF agents. Biologics may be used infliximab. Why this is rare case report? Because some references present, Dogra S and Jadov S on 2010, prevalence is less than 2%, and Resnick Casing, Christina M. Lee et al., July 2016, 1% to 2.25%, and study conducted by Barbara Jo, each at less than 2% estimated among 125 million of patients with psoriasis. Thank you.
Any questions?
Sir, beta blocker, bisoprolol. Sir,
Is it a trigger factor?
Yes, madam. Psoriasis trigger factor.
Any other trigger factors for erythroderma psoriasis in this case?
Madam,
Any other trigger factor you noticed while taking the history of the patient? Was there sudden withdrawal of steroids? Was there any history of it?
In case of, there is no, in case there is no present.
No history. Okay, then I think the trigger factor must be the beta blocker. Okay, thank you.
Thank you.
Next speaker, bone marrow findings show Gaucher's disease. Dr. Rajat Kumar, Deputy Chief Medical Officer, NCL.
Good afternoon to learned judges and all the delegates. I am a pathologist, so I present a very short case and very interesting. And it is an incidental finding, that is a Gaucher's disease. It is a 58-year-old female having history of generalized body pain with intermediate pain abdomen since 3 years. No relevant conservative treatment. Actually, this case has been seen by so many people in my Singrauli district, and one of my physician friend sent it me that we have done all the investigations, everything has been done, but we are not going to the diagnosis. So we are suspecting it is some myelodysplastic or myeloproliferative disorder. So please go the further investigation as you want. So I see all the investigations, there are a bunch of investigations are there. Only two things is remarkable in this case, that is CRP is lightly elevated, it is 20 to 30, and ESR is 78 to 90 in some tests, means out of 9 to 10 tests, ESR is elevated. And USG so grade 1 fatty liver. And the patient has a very interesting complaint. The complaint is that the patient having a pain more in the lower part, and while on the moving, no fatigability. Then I planned for the bone marrow. I did the bone marrow. In the bone marrow, I am very much surprised. I got such type of cells, and it will take 4 days to me to diagnose this case. I refer so many friends. This is atypical cells. In these cells, they eccentrically placed nucleus having a paper crumb-like cytoplasm. It is a macrophages which engulf the cells. So the cellularity is normal, megakaryocytes are normal, myeloid series are normal, and only we are getting the extra other cells like this type of cells. Promyelocytes are also normal. Then in the next slides, I get such clue that is paper crumb-like cells. There are so many cells, these paper crumb-like cells. This is the diagnostic clue, this paper crumb-like cells. Can you guess this paper crumb-like cells, where we are getting? This is a diagnostic clue. So this is the Gaucher cells. So we got the diagnosis of Gaucher cells. As we are working in the Coal India, so it is a very big diagnosis. I'm afraid of giving this diagnosis. So I consult my friend. I gave, it is suspected case of Gaucher's disease. After 2 months, I get a call from NIMHANS Bangalore. They asked for me the slides. I sent the slides. And they did the GABA1 gene. And the GABA1 gene, they asked me that what you are suspecting. I told them that, sir, I am suspecting that is a Gaucher's disease. So what other test you have did? Actually, I have also done PASS. That is PASS stain I have done, but the PASS slides, I haven't kept that slide because that slide was diffusely positive. It was not so much clear. So I told them, sir, I am very much a strong suspicion of the Gaucher's disease. And they told, okay. After 2 days, I get a call from there in NIMHANS, and they told that the GABA1 gene was positive, so your diagnosis is correct. So that's why I present this case here. So the Gaucher cells, I'm telling about the Gaucher cells. Gaucher cells having a very characteristic for the Gaucher disease, the cells having eccentric nucleus and the macrophages having a, that is paper crumb-like appearance. जैसे पापड़ तोड़ते हैं उस तरह का पूरा appearance होता है. So I have also purchased the pictures from the Hirschman, the book Hirschman pathology book. It is showing that the Gaucher cells. Now the pathophysiology of cells is, it is due to the deficiency of glucocerebrosidase, and due to this glucocerebrosidase, the macrophages enjoys with the fatty material, and the cells, the lysosomes inside the macrophages are unable to engulf the cells, and that may lead to wrinkled tissue-like appearance of cells. The cells become swelling due to the fatty tissue, and it becomes the wrinkled tissue-like appearance, and infiltrate into bone marrow, and it causes the Gaucher. It is autosomal recessive disorders. It is of 3 types, type 1, type 2, and type 3. And in this case, most probably it is type 1 because there is no age specific this. It is from childhood to adulthood. And it can differentiate from the pseudo-Gaucher cells. Pseudo-Gaucher cells are seen in the case of myeloproliferative and myelodysplastic disease like multiple myeloma and leukemias. And it is only due to the deficient glucocerebrosidase. So this is all about this case, and I am feeling very proud after presenting this because I am getting a call from NIMHANS. That's why I am presenting this case. Thank you. These are the references.
Thank you, Dr. Rajat Kumar, and I also congratulate you for diagnosing this case as a pathologist. Any questions?
Sir, clinical features here, only one classical clinical feature, fatigue, that is bone pain. Only bone pain. No shortness of breath, fatigability, fever is on and off. It is due to the local infections. And the classical thing is that in this Gaucher's disease, there is a decreased platelet count, there is a decrease in the RBCs and all that, but he doesn't have. He has only anemia. That is, yes, sir. So that's why it took around, he having a symptoms around from last 2 years. She having a symptoms from last 2 years, sir.
Thank you, doctor, for night presentation. Have you done X-ray?
Sir, I don't know because I have get the case referred from a physician, so I don't know detail about the X-rays.
Thank you, doctor.
Thank you, sir.
Next speaker, Dr. Niharika Reddy, Senior Medical Officer, Umrer WCL. Her topic is cerebellar degeneration associated with chronic alcoholism.
A very good afternoon, respected dignitaries, respected CMS, my seniors, and delegates from all the subsidiaries. So, I'm Dr. Niharika Reddy R, Senior Medical Officer at Area Hospital, Umred. I'm here for a case presentation, a case of cerebellar degeneration associated with chronic alcoholism. Alcohol use is leading risk factor for global diseases, burden linking to its consumption for more than 60 of acute and chronic diseases. Amongst them, alcohol-related cerebellar degeneration is one of the commonest forms of acquired cerebellar ataxia. The pathophysiology remains unclear, but the various proposed mechanisms include excitotoxicity, dietary factors, especially thiamine deficiency, oxidative stress, compromised energy production, and cell death. Radiological findings of this disorder is cerebellar atrophy with anterior cerebellar vermis being predominantly affected. Tissue loss in this area is due to either shrinkage of or atrophy of Purkinje cells, large nerve cells that make up much of the vermis. Permanent cerebellar deficits are observed among alcoholics, and they persist even with alcohol abstinence, and they are irreversible. The cerebellum is the structure that controls the stability of gait. Chronic cerebellar diseases and acute alcohol intoxication affect the cerebellar function. The mechanism behind this has been depicted in the further pictures. Subacute and chronic onset of ataxia, nystagmus, dysarthria, dizziness, and cognitive dysfunction are major neurological manifestations of this disease. So this is the picture which shows intracellular mechanisms underlying ethanol-induced cell death and abnormal development. So basically, ethanol causes thiamine deficiency, it causes neuroinflammation, also it causes dysregulation of neurotropic factors. That further leads to accumulation of reactive oxygen species, that further leads to oxidative stress and endoplasmic reticular stress that further activates the autophagy, and that further leads to cell death. So I'm presenting a case of a 68-year-old male patient who presented to emergency department in the month of October with an alleged history of fall injury with impact over his head, shoulders resulting to clavicular fracture and gravel abrasions over the face. He mentioned that he had an episode of dizziness followed by imbalance while walking, and he accidentally fell from stairs. He complained that he has developed dizziness and imbalance since last 1 month, for which he has not taken any treatment. While speaking to him, we have noticed that his speech was not clear. He was able to comprehend words, but he was not speaking with clarity. He gave history that he has developed slurred speech also during the same duration. On further inquiry, he admits he consumes alcohol regularly, but it's a local alcohol since last 30 years, given approximately 120 ml per day. He was a regular alcohol drinker with an Audit C score of 9. The Audit C score is the alcohol use disorder identification test which we use for chronic alcoholism. Basically, it is a screening test which is proposed by WHO for finding out about the alcohol drinking dependency addiction strategies. So the Audit C score for this patient was around 9. Also, for Audit C, we usually see more than 4 and more than 3 in more than 4 in males and more than 3 in females taking it as positive. The positive score indicates greater likelihood of alcohol use, alcohol addiction. Family history was not significant in this case. On examination, his vitals were stable. So this is the Audit screening tool. So there is a questionnaire which includes 10 questions. So that with this tool, we will be able to find out about his dependency on alcohol. Also, so he had bilateral cerebellar signs with SARA score of 25. So basically, SARA score is scale for assessment and rating of ataxia, which is around 0 to 40. His SARA score was around 25. He had difficulty in articulation of words, could not coordinate alternate hand movements, developed past pointing while reaching target, and had a wide-based gait with tendency to fall while walking. No nystagmus and rebound phenomena was observed. His cranial nerve examination was pretty normal. Romberg's test was negative. His liver function was deranged, and ultrasonography was having grade 3 fatty liver changes. His MRI brain with whole spine screening, we had sent it to a panel hospital for his MRI, which revealed bilateral cerebellar atrophic changes with prominent CSF spaces and showing prominent atrophy of anterior portion of vermis and lateral hemisphere of the anterior lobe. With no abnormality, his spine was pretty normal. So this is the T2 weighted MRI images. Figure 1, which is pointed out with a white arrow, shows prominent atrophy of anterior portion of the vermis and lateral hemisphere of anterior lobe. And there's a red arrow that is showing cerebellar atrophy, which predominates initially in the upper anterior vermis, then progresses to the anterior portion of the cerebellar hemisphere, and finally to the lower portion of the cerebellum. The treatment was alcohol abstinence and was treated conservatively with thiamine supplementation, that is 200 milligrams IV thrice daily, and orthopedic management for clavicular fractures. He was also advised physiotherapy, occupational and speech therapy, medications and rehabilitation can manage the effect of cerebellar degeneration, but they are the symptoms are irreversible. Thank you. So he had a history of fall at home. He felt dizzy and he fell. That is, and he had similar complaints since last 1 month, but the fall was what he was brought to the casual as an ER.
What?
So first thing, yes, so hypoglycemia was what we had ruled out. Then second thing was also so maybe diabetes in this case. No, non-diabetic. And then no sir, no, he wasn't under alcohol influence. Yeah, and second thing also could be, since we had checked his motor and tone also. Also third thing is that before getting CT and MRI changes, we also thought about stroke. Yeah. So, but sir, for stroke, his only ataxic was there. Tone and motor was normal, and also power was also good, at around 3. So we ruled out stroke also that way. And also second thing was that slurring of speech was there, but his cognition was okay. So, and then third thing was that he was able to comprehend the words which we were speaking, but the slurring was there. That's why we thought that it could be because of cerebellar signs were more like gait, speech, also stance. No, that time, no sir, his nystagmus wasn't there, and also yeah, incoordination was there, sir. No, not truncal, sir. It was limited to the limbs. Also, lower limbs especially. And also, second thing was that his gait was, he was having a wide stepping gait. With that only we could find out that this is mostly alcohol induced.
Okay. Thank you, Dr. Niharika.
Thank you.
In the management, 1 minute. In the management, what is the most important counseling did you did for the patient? What is the most important thing in your counseling of the patient?
Alcohol abstinence.
Yes, absolute alcohol abstinence.
Abstinence, yes.
Thank you.
Thank you.
Next speaker is Dr. Saidalu Gaddam, Medical Superintendent, Pench Area, WCL. His topic is acute anterior wall ST elevation myocardial infarction with life-threatening complications survived by timely defibrillation.
Good evening all. Myself Dr. Saidulu Gaddam, GDMO from Central Hospital Badukui, Western Coalfields Limited, Pench area. My case presentation is 54 years male, presented with sudden onset of back pain since midnight associated with sweatings and followed by vomiting and fatigue. No significant past history, is a tobacco chewer with no other comorbidities. On examination, dull looking, conscious, well-oriented, vitals are normal. Started symptomatic treatment and advised an ECG. Initial ECG was normal sinus rhythm with some suspicious hyperacute T waves in anterior chest leads. In view of these suspicious changes, we have given loading doses to the patient and admitted, kept for observation, asked to repeat ECG after 30 minutes. Within a short period, he had severe chest pain, became unconscious, rushed to the patient, found unresponsive, no recordable vitals, started CPR immediately. Meanwhile, connected to the defibrillator and delivered a DC shock of 200 joules. Continued CPR for 2 minutes, no response. Repeated DC shock with 360 joules. Continued CPR for another 2 minutes. After continuous CPR of 5 minutes, he reverted back to sinus rhythm and started spontaneous respiration. Immediately after CPR, he had tachycardia, hypotension, hypoxemia, but within few minutes, his vitals improved to normal without any inotropic support and gained his consciousness. Repeat ECG showed sinus tachycardia, right bundle branch block, right axis deviation, and progressive hyperacute T waves in anterior chest leads, which suggestive of acute anterior wall ischemia, which also confirmed by screening 2D echo with RWMA in LAD territory and mild LV systolic dysfunction. Central Hospital Vadkui located remotely, patient has to travel 3 hours to reach cath lab facility, which becomes challenging in acute phase of cardiac event. We had a telephonic discussion with remote cardiologist. His advice was to initiate thrombolytic therapy, discussed with family members, counseled and convinced for thrombolytic therapy, obtained IRIS consent for the same. ECG recorded just before thrombolytic therapy showed conversion of hyperacute T waves into full-blown ST elevation in anterior chest leads, initiated thrombolytic therapy with streptokinase, tolerated, completed without any further complications. After thrombolytic therapy, patient is symptomatically improved and hemodynamically stable. Repeat ECG after 90 minutes of thrombolytic therapy showed significant resolution of ST elevation in anterior chest leads. Shifted to tertiary cardiac center found to have single vessel disease. He underwent PTCA stenting to mid-LAD. After adequate rest and cardiologist review, resumed back to his duty, completed his service, his 6 years of service after major cardiac event and retired recently. Conclusion, sometimes presentation of acute coronary syndrome may be atypical. Early diagnosis and continuous monitoring for life-threatening complications of acute STEMI plays an important role, as they are very prone to develop many life-threatening complications in the acute phase of MI, especially ventricular arrhythmias. They are often causing death in first hour. So, timely decision and intervention decides the patient outcome. Even with minimal resources at remote setup, by prompt usage of available tools can save many lives. Central Hospital Vadkui being a remote setup catering to 3 areas of WCL, Pench, Kanahan, Patharkeda. Over last 10 years, we have successfully stabilized 168 patients of acute ST elevation myocardial infarction by thrombolytic therapy and shifted to tertiary cardiac center for definitive management. I am very grateful to be a part of Coal India medical team to serve rural India. Thank you.
Any questions?
Ventricular arrhythmia, sir, VF. So we don't have facility to record that, sir.
What are the complications of streptokinase?
Can be allergic reactions, IC bleed हो सकता है, systematic bleed हो सकता है, sir.
Okay.
Survival after defibrillation in ventricular tachycardia, arrhythmia.
Pardon, madam?
In ventricular tachycardia, what are the types of ventricular tachycardia? Early and
It can be ventricular fibrillation or ventricular.
Yes, what is it? Ventricular fibrillation or tachycardia before occurring within what is early and late ventricular fibrillation?
DC shock.
You are not getting her question. She is leading you to answer what is the precursor of ventricular tachycardia. What do you get in ECG or what changes?
It may be infarcts.
That's all right. In ECG, what do you get?
I mean to say in early ventricular tachycardia or fibrillation, how will you counsel the patient's relatives? If it is early, then the prognosis is not very bad, I think. And if it is late after 48 hours, then the prognosis is not so good. This is what I wanted to ask you. Thank you.
Madam.
Next speaker, Dr. Naga Jyoti, Deputy Medical Superintendent, Chandrapur Area WCL. Her topic is adenocarcinoma right lung with brain metastasis.
Good afternoon, respected judges and all the delegates. My name is Dr. Nagajyoti K. I'm a DYMS from Chandrapur area, WCL. I'm going to present a case of adenocarcinoma of right lung with brain metastasis. Coming to the introduction and epidemiology, it is a distinct entity. Carcinoma of the lung in never smoking women is increasingly recognized as a clinically distinct entity. It is often characterized by specific molecular drivers, primarily adenocarcinoma histology and genetic mutations such as EGFR. And the risk factors include the environmental tobacco exposure and household air pollution. Coming to the genetic factors, radon exposure or genetic predisposition to the EGFR mutation, like having a first degree relatives with lung cancer. Prevalence, significantly higher prevalence observed in East Asian and South Asian women. Coming to the case history, a 63-year-old female housewife, non-smoker, diabetic, came with the complaints of persistent cough with sputum for more than 2 months associated with progressive dyspnea and fatigability, low-grade fever and chest pain with a significant weight loss, and there is no history of hemoptysis and no past or family history of tuberculosis, bronchial asthma or COPD. Coming to her clinical examination, and general examination, she is having mild pallor, no icterus, no cyanosis and clubbing. She is conscious oriented and oriented to time place person. Her S1, S2 were normal and normal sinus rhythm. Perabdomen was soft, no organomegaly. Coming to her respiratory system, on inspection, chest was bilaterally symmetrical, mild tracheal deviation to the right, and no dilated veins or sinuses. On her palpation of the chest, decreased respiratory movements in the right suprascapular region, and the chest is non-tender with decreased vocal fremitus in the right suprascapular region. Coming to her percussion and auscultation and percussion, dull note on the right suprascapular, infrascapular and right mammary regions. Remaining all areas of the chest were, all percussion was resonant note. And auscultation, decreased air entry in the right upper zone associated with bilateral creps more in the right than left, associated with occasional rhonchi. Her initial investigations, which includes her hemogram, which was showing 9.5 grams hemoglobin, TLC was raised 16,700 cubic millimeters, and platelets were normal. Her blood sugars was raised as she is diabetic. Her fasting blood sugar is 162, and postprandial blood sugar was 300. Her LFT cavity were within normal limit. To rule out the to rule out the tuberculosis, her sputum for AFV was done. It was showing negative. Coming to her chest X-ray, PA view was showing mild right-sided pleural effusion. On her chest X-ray AP view, it was showing ill-defined mass in the right upper zone with a perihilar extension and prominent bronchovascular markings on right side associated with the bilateral hilar lymphadenopathy. And further evaluation with CECT thorax, there is a heterogeneously enhancing large soft tissue lesion in the perihilar region of the anterior segment of the upper lobe, associated with enlarged lymph nodes in pretracheal, paratracheal and subcarinal, hilar and prevascular areas, and associated with minimal right-sided pleural effusion, and lytic lesions in posterior spinous process of the D7, D11 and D12 vertebrae. As she is having mild right-sided pleural effusion, thoracentesis was done to rule out the tubercular etiology, and it came negative. Then after examining the CT thorax, further a patient investigated with CT guided biopsy of the soft tissue lesion in the right upper zone of right lung with under the local anesthesia, and it came her histopathology was showing adenocarcinoma, non-small cell lung cancer, which is characterized by the glandular cells. And further her molecular study was done to identify the genetic mutation. It came positive for the EGFR L5586 gene mutation with exon 21. During the course of treatment, patient further developed altered sensorium and further evaluated with MRI of brain. It was showing multiple foci suggestive of metastatic lesions in both frontal, parietal, temporal and occipital lobes and bilateral cerebellum. Later, she underwent PET scan. It was showing heterogeneously enhancing metabolically active large soft tissue lesion in the anterior segment of right upper zone associated with metabolically active mediastinal lymph nodes and metabolically active numerous neuroparenchymal lesions in her brain, along with the peripheral metabolically active metabolically active lesions which suggestive of coexisting infection in her lungs. Later, she received the treatment of palliative radiotherapy targeting her whole brain and spine, which is 40 gyri for 15 cycles, along with the targeted therapy. As she was diagnosed with the EGFR gene mutation, she was advised targeted therapy with tyrosine kinase inhibitor, third generation tyrosine kinase inhibitor, tablet osimertinib 80 mg. Patient responded well to the treatment, and she is hemodynamically stable at present. The key takeaway includes the lung adenocarcinoma in non-smoking women is a distinct entity, often driven by the EGFR mutations. Early molecular testing is crucial as it opens the highly effective targeted therapies like osimertinib, even in advanced stages with brain metastasis.
Thank you, Dr. Nagajyoti.
Thank you, ma'am.
Any questions? Why did you select this case? I mean, it was a case of adenocarcinoma lung.
Actually, I diagnosed this case, ma'am. She came to me personally. She is a dependent. one of the hospital staff's mother, she came to me. And regularly in the winter seasons, we diagnose lung cases as chronic bronchitis. We misdiagnose many cases. In this case, there was a mass which is different from the tubercular lesion. So I further advised them for the investigations and all, and referred to higher center as my hospital is not having the facility.
Yes.
And the diagnosis came out to be adenocarcinoma. The two medical oncologists performed a molecular study, genetic testing, new generation sequencing. It came EGFR positive.
Yes, I think I must congratulate you because you diagnosed the case. Otherwise, many times adenocarcinoma lung, they present directly as brain metastasis. So
Yes.
she just presented with altered sensorium and you diagnosed brain metastasis also.
Yes.
So that's very good. Thank you.
Thank you, ma'am. Sir. Sir? Non-smoker, sir. My case is a adenocarcinoma of lung in a non-smoking women. Sir, for first 1 month, osimertinib 80 mg daily given, sir. After 1 month, she is now on osimertinib 80 mg once in a month for 6 months. After that, medical oncologist is going to add her chemotherapy. Now the standards are changed. They are giving targeted therapy with the chemotherapy. Sorry, sir. I don't know. Sir. Sir, currently she is maintaining stably only, sir. Sir. Oh, sir. Actually, she is currently on osimertinib once in a month dose, sir.
Okay.
Hello. This is a high-cost therapy, usually suggested by the corporate hospitals and different. And after few patients I am sent to the TMH Mumbai, then he suggests the 3 months to 6 months. After that he has tapered the dose and then suggested for the second line of treatment.
Yes.
Okay, thank you.
Thank you, sir.
Next speaker, Dr. Sukh Sagar Vaishya, Senior Specialist, Orthopedician, NCL.
Good evening, respected judges and respected delegates. Today I am going to present a very challenging case of a young adult who met with an accident around 4 years back. He met with an accident because of an auto collision, and approximately 18 centimeter bone loss was there. As he was a young patient, so amputation was undesirable, And so there was a need for biological limb salvage. There was also option of the tumor processes, but it was ruled out because the wound was so much contaminated, and there was a chance of infection, and also the cost factor was there. So we decided to put an Elizaro on this patient. Something about Elizaro, it's an external ring fixator devised by our great scientist Elizaro from Russia. It works on the principle of distraction osteogenesis. Bone grows slowly at the rate of 0.5 to 1 millimeter per day when we distract gradually. It's mainly used in trauma, infection, and massive bone loss. Our reconstruction strategy was that application of the Elizaro ring fixator, corticotomy at the site, gradual distraction at the rate of 1 millimeter per day until the gap is filled, and the trial for the knee arthrodesis. Timeline was for this first day surgery, and on 14th day there was distraction of the corticotomy site at the rate of 1 millimeter per day, and at around 6.5 months the desired length was achieved, and at around 9 months because of TA contracture I did the tenotomy, and at around 15 months there was a radiological finding of solid consolidation, and hence the ring was removed. This is a pictorial diagrammatic showing that this is the proximal, this is the distal, and we transported the bone from here to here. The next slide shows better. This is the slide. Because of infection, the part of bone is removed, so we did the corticotomy here. From here, we started transporting the bone to here, and at the time, the bone was reached here. Now again to the case. He's a young 24-year-old male. So he was put on Elizaro and tried for the knee arthrodesis. 6 months distraction phase, 9 months tenotomy for the equinus, and 15 months this. This is the initial picture. We did convectional fixator earlier, and later on we applied the Elizaro ring fixator. This is the immediate post-op picture. You can see this huge bone loss from this to this. Even his knee joint was destroyed, and so much contamination was there that even before applying the ring, we gave him option for the amputation, but he was not desirable because he was a young chap. This is the 1 month operation. You can see this distraction is started. This is the clinical picture showing this Elizaro on his limb. You can see there's little bit bowing here because of long length of transport. This is after 9 months, full length was achieved, and this new bone, we can see this new bone is there. This is at the around 15 months, full length was achieved, and near arthrodesis was there. So complications I met during this huge transport was that he developed ankle equinus because of soft tissue contracture. So at around 9 months, I did that tenotomy of the tendo Achilles. It improved his dorsiflexion, gait was restored. There was slightly bowing of the tibia, which was well tolerated, and he could walk properly. So why this case matter? Because this is a massive 18 centimeter reconstruction. Complete limb salvage was there, and it was cost-effective biological solution. And it was a well-functional outcome was there. So key take-home message is there: massive reconstruction could be achieved, can be achieved with Elizaro technique, and timely TA autonomy could have improved his gait better because bowing of tibia would not have occurred. So Elizaro remains powerful in complex trauma. This is his recent video he sent to me. Not play. I'll play later. Play होगा कैसा? इसमें है, इसी में है. कैसे? Folder में था. Thank you.
I must congratulate you for salvaging a young boy's leg by this surgery. Any questions?
Actually, the gap was so much, 18 centimeter. So other than this technique, most easiest would have been amputation for him. but as he is a young patient, so I have not advised for him. Another option was that long tumor processes, which that tumor guys also do, but it was so much crush injury, contaminated, it would have been infected, so I also ruled out that condition. This, yes. Yes, sir, it was much longer, it requires patience of the patient also, but he was very good. Everything I explained to him that it would require 15 to 16 months of this whole process. He agreed, but he wanted to save his limb at any cost. So he agreed for this, sir.
First of all, I would like to congratulate you for having the courage to take up such a challenging case, having a compound injury with such a massive bone loss and opting for limb salvage. Regarding going through your slide, I think bowing of tibia is a very expected complication for such a bone loss. How do you think that it could have been minimized, this expected complication for such a case?
Actually, this huge transport is, actually we used to transport 5 centimeters, 6 centimeters routinely, but 18 centimeter transport is very unusual. So I have not anticipated that this much bowing will occur. Usually, along with the bone transport, tissue also will also expand. But for 18 centimeter tissue to expand is very rare. So I would have anticipated that this may occur, and I would have done tenotomy earlier also.
Yes. You had done tenotomy at 9 months.
Yes, it was a bit delayed
It
because
would have
I have
been
not
done
anticipated.
at around 6 months. And what about jet plasty for this case?
Jet plasty would have avoided him from weight bearing actually. Jet plasty requires some rest for that.
Okay. Thank you.
Thank you, Dr.
I would like to play the video. This patient. Sorry.
I request all the speakers of the case presentation, Dr. Arijit Banerjee, Dr. Satish Madavedi, Dr. Kalol Bhaumik, Dr. Rajat Kumar, Dr. Niharika Reddy, Dr. Saidulu Gaddam, Dr. Nagajyoti, Dr. Sukh Sagar Vaishya to please come on stage, and I request our judges to felicitate them.
योर करतल ध्वनि आपकी ज़्यादा प्रोत्साहन देंगी। ये हमारे सभी अपने ही साथी हैं जो कि एक्स्ट्राऑर्डिनरी काम अपने ही सर्कमस्टांसेस में कर रहे हैं।
Dr. Sanjay Singh sir, AMO Hasdev, to felicitate our esteemed judges.
scientific session is closed, but there are two very important announcement. One is all that. One is my request. Our delegates are enjoying this academic feast or not? So tomorrow we have our most of the guest speakers are coming. So it is my humble request to everyone, because topics chosen not according to particular subject or particular branch, but topic chosen for general public. And it is our duty also that our hall should be full when our guest speaker is going to deliver their talk. So sharp 9 o'clock, I request everyone should be in hall, so that guest speaker doesn't feel bad that hall is empty. Second, delegates who are residing in this Chawla Greens, they are requested to collect their delegate kit from room number 1001, which is a control room. Because this delegate kit is not delivered at reception due to the big size of that. And those who are our esteemed guests, I will send their gift to their respective room also. But those who can collect it, please collect it from room number 1001 at first floor, which is a control room. And tomorrow's program is as per schedule, which is given in booklet. So all are again requested, and thank you very much for coming here and attending today's scientific session. But scientific session has closed, not the program. So you all are cordially invited at this Chawla Greens poolside, because we have arranged a very good cultural night where the India topmost Saregamapa singers are coming. They already have arrived here. They have checked in this hotel. Stage is on to fire for music. So please, you all are welcome 7 p.m. onwards at this Chawla Greens poolside grounds. All are requested to come there. Thank you very much for coming here and participating. Thank you very much again. Any other? Thank you.